Thank you for joining this afternoon for the day 4 of Amscon 2020. So this evening brings together two fields that sit at different
ஜூலியட்
points.
எல்லாத்தையும் மியூட் பண்ணுங்க.
பண்ணுங்க சார்.
Sir, just unmute, sir.
Am I audible now?
Yes, sir. Audible, sir. Yes, sir.
So good to see Dr. Venkatachalapathy also. Welcome, sir. So this evening brings two fields together at very different points in patient's life. It share the same precision and same demand for precision. Fetal medicine and breast cancer both remind us that early, accurate imaging and timely decision making in medicine changes outcome profoundly. We open with fetal medicine. Dr. S. Lakshmi Ravi will take us through the ultrasound evaluation of early pregnancy bleeding, followed by Dr. P. Devarajan on Doppler in fetal growth restriction and that crucial clinical questions when to deliver. We then move to breast cancer across the full continuum of care. Cover the imaging options. And our joint secretary, Dr. Mohammed
ஜூலியட் இது போடுங்க.
So you're muting everybody. Okay. So Dr. Mohammed Ibrahim will cover the recent advances in surgical management, and Dr. Syed Ismail on medical management in the era of targeted therapies, and Dr. Prabhuraj will close with radiotherapy techniques. So I welcome all the speakers and thank you for accepting our invite and willing to share your time and expertise with our delegates. So my sincere thanks to the national leadership for the steady support, to our moderators and faculty for their generosity, and all of you making the time, and more importantly, our IMA Tamil Nadu State Leadership, President Sridhar, the President-elect Dr. Ravi Kumar, the Secretary Dr. Dharavya Mohan, the Treasurer Dr. Solomon Jaya, and Dr. NRTR and all the state leaders for their continuous support to our AMS initiatives. And this conference has been the hard work of Dr. D. Senthil Kumar and the entire IMA Pollachi team and our joint secretary. With their effort, we have over 4,000 delegates joining us in this 5-day-long AMS conference. So with these few words, I welcome all of you for this day's deliberation. And over to you, Senthil, for taking over the proceedings.
Thank you, sir. Now I request our National AMS Chairman, Dr. Venkatachalapathy, sir, to give his felicitations and inaugurate this session.
Good afternoon, everyone. At the outset, I would like to thank Dr. Chandan and Dr. Nirmal Frederick for inviting me for this wonderful session. In fact, I've been in touch with Dr. Chandan regarding the happenings that are there going on in IMA AMS Tamil Nadu. And I should say that Tamil Nadu is doing a wonderful work in IMA AMS. And it was a proud moment for IMA AMS to have hosted for such a wonderful conference with almost 4,000 people benefiting by this conference. Now, as it is IMA AMS, we have got around 20,000 membership at the national level with the 20 state branches and 230 local branches. And it's increasing by the day. That is the good news. And second, very important that has happened yesterday is that I want to share this information because we did had a MOU with Baba Farid Medical University to give some kind of a legal validity to our certificates, what we give during our fellowship courses. We are running around 42, 45 courses at almost 55 centers all over India. But hitherto we used to give only certificate given by IMA AMS. After this MOU, I think Now the Baba Farid Medical University will also be part of this certification process, and that is a very good sign and a good sign of the growth of our wing of IMA. So, and what important thing is that uh, what hitherto the MOU is to require our candidates to go to Punjab, somewhere in Punjab, and stay there for about 15 days or a week to get certification. Now, the Punjab University has been a bit liberal and they are agreed to online even course also. So, thereby it was a good sign what we had yesterday meeting with the Punjab, the medical university. With that, I think coming to today's topic, fetal medicine and breast cancer. Fetal medicine is a wonderful area of science, which usually helps to detect early problems in the neonate, and that brings down the unnecessary burden of a handicapped child to be born and to be looked after throughout the life by the family, and it's a drain on the family rather, I would say. Second thing is, even though with so much of development, still we see a lot of breast cancers. And today, I think we would learn what is the recent developments about this disease also. So, with those introductions, I would congratulate the IMA AMS Tamil Nadu and also the local branches. And I thank all the office bearers of IMA and IMA AMS for giving me this opportunity to be part of this wonderful program. And I welcome each and every AMS that is happening in Karnataka and during the September 5th and 6th. And we have a great scientific feast that will be happening. So I wholeheartedly welcome everyone for the conference, and you be please come and enjoy the scientific feast and the hospitality of us, Hubli, Karnataka. With those words, I conclude and wish this conference all the best. Thank you so much for giving me this opportunity. Thank you once again.
Thank you very much, sir. We will all share your brochures in our group, sir. Sure, sir. Now I request our National AMS Secretary, Dr. Sairam, sir, to give his felicitations.
Thank you. I'll be available tomorrow in person, and I'll be happy to be continuously for the last 2-3 years. I've been coming regularly. I'm very happy with Tamil Nadu for their hospitality and academic activities. Presently, I am actually in a healthcare summit in one of the national meetings in Hyderabad. So, with thanks, I am including my remarks. But definitely tomorrow all day and after tomorrow morning, I'll be available for physically with you. Thank you for inviting me. Thank you.
Welcome, sir.
Thank you so much, sir. Sir, now we will move on to the session. And first is fetal medicine. So now I'm happy to introduce our moderators, Dr. Aishwarya Bette Gowda, fetal medicine consultant, expert in maternal fetal imaging, and Madam is currently working in Kaveri Hospital, Hosur, Tamil Nadu. Her specialization is with advanced training in prenatal imaging, fetal diagnostics, maternal and fetal medicine, experienced in fetal anomaly screening, counseling, research, and academic presentations. And other moderator for the day, Dr. Prabhakar sir, MS General Surgery, Professor of General Surgery, Chettinad Hospital and Research Institute, Kelambakam. I welcome you, sir, and hand over the session to you.
Thank you, sir. Thank you.
Can we start?
Yes, madam. Madam, you can introduce the first speaker, Lakshmi Ravi, madam, and proceed with the session. Wonderful session. Yes, madam.
Good afternoon, everyone. I'm Dr. Aishwarya Bette Gowda, obstetrician and gynecologist, and currently a consultant in fetal medicine, Kaveri Hospital, Hosur, and Sri Lakshmi's Cancer Center, Krishnagiri. It is my pleasure to welcome you all for day 4 of TN Amscon 2026 for today's online academic session on fetal medicine and breast cancer. Our first scientific session is on ultrasound evaluation of early pregnancy bleeding. This is a topic that every obstetrician, radiologist, fetal medicine specialist encounter frequently. It remains one of the most common obstetric emergencies in clinical practice. Although many pregnancies continue normally after a single episode of bleeding, it may be the first manifestation of miscarriage, ectopic pregnancy, gestational trophoblastic disease, or conditions that require prompt diagnosis and timely intervention. So, ultrasound evaluation combined with careful clinical assessment and follow up becomes the cornerstone of managing these patients. With that introduction, it is my privilege to invite our first speaker, Dr. Lakshmi Ravi Selvaraj ma'am, consultant and director of Sri Lakshmi Scan Center, Krishnagiri. She is one of the pioneers of the field of fetal medicine with over 20 years of experience, a renowned academician, national faculty, and an accomplished researcher with numerous publications to her credit. Ma'am, it is an honor to have you with us. I hand over the session to you. We look forward to engaging presentation, encourage the audience to post their questions. It will be taken up during the discussion.
Good afternoon, everyone. Am I audible? Is my voice clear?
Yes, ma'am. Yes.
Yes. Thank you, Aishwarya, for those kind words of introduction. Is my slide visible? Is my slide visible?
Yes, yes.
Yes, madam.
Great, great, great. Thank you, organizers of the IMA, for having put us all through this great academic platform. And I understand the passion of the delegates. So many people have logged inside for fetal medicine. Thank you. Thank you, all the delegates. Thank you, IMA organizers. And coming to the topic on ultrasound evaluation of early pregnancy bleeding. As just now Aishwarya said, this can be something very, very benign to something like a life-threatening condition. So the objectives of the presentation would be, first of all, a simple implantation. Bleeding is again one of the most simplest benign causes, or we can have a subchorionic hematoma or a failed fetal growth, an ectopic, or a very life-threatening condition like a cesarean scar pregnancy. So the spectrum is diverse, and hence we need accurate ultrasound diagnosis in early gestation. So the whole topic is now based on understanding the normal ultrasound features of early pregnancy. When do we say it's a non-viable pregnancy? Is there a pregnancy in an uterine anomaly? To recognize life-threatening conditions like ectopic pregnancy and a cesarean scar pregnancy, and the importance of identifying a low-lying gestation sac, and also the ultrasound feature of a molar pregnancy. So when we take ultrasound features of early pregnancy, the earliest sign of intrauterine pregnancy is a small fluid-filled sac. So this is the gestation sac, and this is visible as early as 5 weeks of gestation. At 5.5 weeks, you will see the yolk sac, and at 6 weeks, you can see the embryo with cardiac activity. So this is the gestation sac, which you can see as early as 5 weeks, and you can see the G-sac eccentrically located in the endometrial cavity, and this is the endometrial cavity line. So ideally, the G-sac is always positioned in mid to the upper uterine cavity, and it will be surrounded by a hyperechogenic rim, and by 4 to 5 weeks of gestation, you will be able to see this sac. So when you have a bleeding in early pregnancy, so the first your motive is to identify the presence of the gestation sac and identify where is the G-sac located. Whenever you see a yolk sac inside the gestation sac, you're very sure that it's an intrauterine pregnancy, and that is the first anatomic structure which is identified within the G-sac. Then comes the crown rump length. So when we see a gestation sac, then it is 5 weeks. If you see a gestation sac plus yolk sac, 5.5 weeks. A G-sac, yolk sac, and an embryo is 6 weeks. And when you see a CRL of greater than 5 millimeters, you will be able to see the cardiac activity. And we always measure the crown rump length when it is more than 7 millimeters. Once we assign the gestation age, then we do not change this in subsequent scans. Now, this is how we evaluate an early pregnancy ultrasound, and we will see the deviations. When we diagnose a miscarriage or a failed fetal growth or early pregnancy failure, we must remember the fundamental principle is primum non nocere. First, we should do no harm. So we should not mislabel a growing pregnancy as early pregnancy failure. So if you misdiagnose, then it is unacceptable and it will lead to inadvertent termination of a viable pregnancy. That means we should know the criteria. So by a transvaginal scan, when you have a GSAC of greater than 25 millimeters and you don't see the embryo, then you can say it is a non-viable pregnancy. But still, if it is less than 25 millimeters, then better we do a repeat scan. If you have a crown rump length of greater than 7 millimeters and you don't see cardiac activity, only then we see failed fetal growth. Under all other conditions, we need to repeat an ultrasound after a week and check for the viability. So when you cannot see the gestation sac, that is, there is a positive beta HCG, where you have bleeding, the patient presents with the bleeding, and you can't see the sac in the uterus, then what do you do? If there is a normal adnexa and you have a rising beta HCG titer, then we wait to see whether there is a sac in the uterus or it is going to be a ectopic gestation. If there are declining titers, positive beta HCG, declining titers, normal adnexa, then we may be dealing with a miscarriage. If there is a positive adnexal finding, then it's an ectopic gestation. So that's how we take across. Whenever we have a beta HCG, you need to have a zone, a discriminatory zone. Only when the beta HCG is more than 1500 to 2000 IU, you will be able to see the gestation sac at all. So if you have a beta HCG, then you have to wait for the doubling time of beta HCG. And in a normal viable pregnancy, the doubling time is about 48 hours. In ectopic, serum HCG levels will rise at a much slower rate. You will have a less than 60% increase over 48 hours, but it will not be steadily declining. Because if it is steadily declining, then you will think it is a failed fetal growth. Hence, it is important to always correlate ultrasound findings with the beta HCG values and then arrive at a diagnosis. That's why your clinical evaluation, beta HCG and ultrasound finding should go hand in hand to identify the exact situation in the patient. The serum beta HCG test yields positive results at approximately 23 days before a normal intrauterine GSAC may be imaged. So that also we need to be cautious because your beta HCG might, that's why we have to understand the discriminatory zone. Because you still can have a beta HCG, you may not see the GSAC. If you wait, you will be able to see the GSAC in the uterus. When we come to an ectopic pregnancy, the criteria for an ectopic pregnancy is an adnexal mass that contains a yolk sac or a viable embryo. An extra ovarian adnexal mass is the most common finding. You will be able to see a tubal ring sign or free fluid in the pelvis. Now, what is a definitive criteria? So, first of all, you must see an adnexal mass, and inside the adnexal mass, you will be able to see the yolk sac or the CRL. If you see an adnexal lesion with the yolk sac or the crown rump length, you can definitively say that this is a ectopic pregnancy. But commonly what we see is, you will see an inhomogeneous extra ovarian adnexal mass because most often it may go in for a rupture and you can have an organized hematoma like this. So that is called as the blob sign, or you can have a tubal ring sign, a sac-like structure which is called as the bagel sign. These are the most common findings what you see in an ectopic pregnancy, and you look at the free fluid with internal echoes. So this is an ominous sign. So whenever a patient presents with early pregnancy bleeding, if you're not able to locate the GSAC in uterus, then we have to do a meticulous scan of the adnexa to rule out an ectopic. Now, sticking to the criterias. So whenever we have when we see the patient for the first time, you don't have an early pregnancy scan. And we see a patient for the first time, she comes with bleeding. She may not be sure of her dates. See, look at this. This is an irregular fluid collection in the uterine cavity. She is a preemie who conceived after 6 years of infertility. By menstrual period, she is 8 weeks. Now she's presenting with history of bleeding PV. And she came to us for a second opinion suspecting early pregnancy failure. Now, you see a big G sac like this, but you do not know whether it is truly a gestation sac. It can also be some fluid collection inside. So ideally, what we did, we just said, okay, we have nothing to lose. We will wait after a week to see what happens. Look, after a week, what happens? You see the GSAC appearing. That is why the beta HCG becomes positive a little earlier. So you wait for the discriminatory zone of beta HCG, and then you see a small GSAC here. What you saw here was just some collection. That was not the GSAC. This is the GSAC, and another 2 weeks later, you nicely see the crown drum length and a growing fetus. So the key home message in early pregnancy bleeding is you have to be very careful in diagnosing early pregnancy failure. Ultrasound is a very strong tool, but no single ultrasound measurement can predict pregnancy failure 100% all the time. It should never be used in isolation, especially if the pregnancy is desired. Hence, a combination of clinical judgment, HCG, ultrasound findings, and repeat ultrasound. Remember, by waiting, we do not lose. By a meticulous scan, we wait, we repeat ultrasound, we check with beta HCG titers, and then you must always be sure what we are doing in the diagnosis of management of early pregnancy failure. So again, when whether you diagnose early pregnancy failure or an ectopic, you have to be cautious, and you always have to look for that free fluid with internal echoes when you're dealing with an ectopic, because that is a very sure sign that there can be a hemoperitoneum. Now coming to some simple features, but it might look little threatening on ultrasound, that is called what is called as a chorionic bump. Patients who are presenting with bleeding, they will have a good crown drum length with cardiac acuity. The fetus might look normal, but you will see a structure like this, and this is nothing but a chorionic bump, and it will resolve by itself. We need not alarm the patient when we see some findings like this when the patient has bleeding. These chorionic bumps generally tend to resolve by itself. You can sometimes have large subchorionic hematomas, and whenever you have a hematoma, it can either be small or it can be a very large hematoma greater than the size of the GSAC. But the idea is you just check for viability, check for the cervix, and we have to conservatively monitor for resolution of this hematoma. But whenever you see a hematoma, always check for the appearance of the hematoma in relation to the GSAC. Because see, if there is a large hematoma sitting here, and you should not simply pass it off that this is only a subchorionic hematoma and settle by itself, because the GSAC is low lying and the hematoma is on the upper part. If you have a low lying gestation sac, then this hematoma has some very much significance, because this low lying gestation sac can be a harbinger of a cervical pregnancy, a cesarean scar pregnancy, or a low cervicoisthmic implantation. Hence, the position of the hematoma in relationship to the gestation sac needs always to be evaluated in ultrasound. So look at that. Whenever we have a GSAC, it is always located in the upper half of the uterus. If you have a gestation sac, low lying, then you can have a host of conditions. If you have a GSAC not in the middle of the uterine cavity, but somewhere eccentrically located GSAC, again you can have some situations which we need to discuss. So what we have just now finished is, we finished with the GSAC, a failed fetal growth, and with a complete adnexal mass. Now I'm going to tell you about gestation sacs which can be inside the uterus but still are considered as ectopic. What are those? So when we have a low lying gestation sac, then you can have a low implantation of the sac, which can lead to morbidly adherent placenta. This can be a simple inevitable abortion which will have a benign outcome in majority, or you can have a cervical pregnancy or a cesarean scar pregnancy, and both of them are life-threatening conditions. So again, ultrasound plays the key role in distinguishing between all these four types whenever you have a patient presenting with early pregnancy bleeding and you see a low-lying GSAC on ultrasound. So the criteria for a scar pregnancy would be You will have an empty uterus. You will have an empty cervical canal, and you will see the gestation sac nicely sitting on the scar site. And you see, this is the cesarean scar site, and the G-sac is sitting exactly located in the scar site. And look at this peritrophoblastic flow. So this is a life-threatening condition because you see, this sac will start growing outside and it will go for a rupture if we don't identify the gestation, the cesarean scar pregnancy early in gestation. The diagnostic criteria for a cervical pregnancy is the G-sac is exactly located in the cervical canal. You will have presence of peritrophoblastic flow, but you will have healthy myometrium in the anterior wall and the G-sac. But here what will happen, the residual myometrial thickness will be very, very thin in a cesarean scar pregnancy because the sac actually grows into the scar and outside the serosac. Whereas in a cervical pregnancy, you will see the entire sac inside the cervical canal. When you say think about inevitable abortion, you will see the products of conception outside, and you will see there is a splaying of the lips of the cervix. But when you see this something like this, then you know that this is going to simply go away because now this is in the process of an abortion. This is what you're seeing here. When you apply a color on it, color Doppler on it, there will be no color pickup because it is just here the whole entire products of conception which is trying to come out. But again, here on ultrasound, you have to be little careful to have the differentiation features between and what is an inevitable abortion, what's a cervical pregnancy, and how do you handle a cesarean scar pregnancy. This is a paper published from our center, and here we have a very clear approach of how you have to approach a low-lying G-sac in early pregnancy. And this is how you correlate with the presence of beta HCG, position of the G-sac, ultrasound appearance, and the color Doppler. What I have explained so far is given in the form of a table in this particular paper. Now, I'll just give you a condition which we may all tend to miss out. When you have a picture like this, yes, you know this is going to be a products of conception which is coming out of the uterine cavity. But look at this. Both are looking similar, but when you apply color Doppler, you will understand that this is not a product of conception. Actually, the os is actually closed. It's not open. It is the entire placenta which is implanted, and you see the pickup. So unknowingly, if you do a curette, she will have a life-threatening bleeding here, and that is where ultrasound plays a key role in identifying a low implantation of the placenta from what is a simple inevitable abortion. So now this is the what was in the table. You can have an easy approach. So whenever you have a low-lying G-sac, the first thing what you will do is check for peritrophoblastic flow. If you have complete absence of peritrophoblastic flow and you gently push the probe, you will be able to see the sliding sign positive. And you know it's nothing at all. It's a simple cervical stage of miscarriage. But whenever there is presence of peritrophoblastic flow, you will know that the G-sac itself is implanted there. So is the G-sac inside the cervical canal, then it's a cervical pregnancy. If it is in the scar area and the anterior myometrial thickness is between 1 to 3 millimeters, then you know that this is a cesarean scar pregnancy and this is a life-threatening condition. If you have a low-lying G-sac and the anterior myometrial thickness greater than 6 millimeters, then you might have a morbidly adherent placenta, and hence we have to watchfully observe this pregnancy in mid-trimester to check for the placental position. So a simple low-lying G-sac, early pregnancy bleeding, this is how you will approach. You will have a systematic way of doing the ultrasound and correlating with the findings. Now I finished the low-lying G-sac, and I'm now going to take you to the eccentrically located gestation sac. So what will happen? Whenever you have a G-sac in a, you see this is the uterine cavity. You can see the sac, but it is not inside the G-sac. It is located little laterally, eccentrically located G-sac. Again, this is a finding which needs very, very meticulous evaluation on ultrasound. The patient may present with this pain abdomen and bleeding PV. And how do you look at that is, look at this. Now you are seeing the sac sitting here, but it is sitting in the interstitial portion of the uterus because the endometrial cavity is separate. So the sac is separate from the endometrial cavity. Look, this is the endometrium. This is the G-sac, and this is an interstitial pregnancy. This is where 2D correlated with 3D will tell you this is an interstitial pregnancy, and this again is a life-threatening condition. But not all eccentrically located G-sacs are life-threatening. We only have to see where the G-sac is located. See, this one is located in the lateral angle of the endometrial cavity, but the sac is completely inside the endometrium. It is not outside the endometrium, as I showed you previously. So that means, look at that. In the next picture, you will understand with 3D, we have identified that this is an angular pregnancy. The sac is inside the endometrial cavity. Only thing is, this is not life-threatening, but you just have to wait and watch to see whether the sac will grow medially or laterally. If it grows medially, then there is no problem. But if it grows laterally, there can be a myometrial thinning. So this you have to wait and watch. So one is a very life-threatening problem, which is an interstitial pregnancy. This is okay. This is an angular pregnancy. And the true cornual, what's a true cornual pregnancy? A true cornual pregnancy is one which is located in a uterine anomaly. So that is, again, we have to be clear. If it is a unicornuate uterus and if the pregnancy is located in a rudimentary horn, then again, that is a very, very life-threatening condition, and you will have no visible continuity between the endocervical canal and the lumen of the pregnant rudimentary horn. So look at that. You have a uterus here. You see a G-sac separate from the uterus. It is surrounded by biometrium, and there is a vascular pedicle joining the G-sac to the unicornuate uterus. Again, you should not allow this pregnancy to grow, because what will happen inside a rudimentary horn, it will once again go for a rupture. So look, this is a unicornuate uterus, and this is a gestation sac. Patient is presenting with bleeding PV, severe abdominal pain. You understand that this is a pregnancy located in the rudimentary horn. That is why whenever you locate the G-sac intrauterine, or you locate the G-sac, you look at the embryo, we always check for continuity of the cervix, because here this rudimentary horn will never have continuity with the endocervical canal of the cervix. So these are the key features in ultrasound, and that is why a referral to an immediate ultrasound will help us in early diagnosis of these life-threatening conditions. So to conclude, eccentrically located gestation sac, this can be an ectopic when it is either an interstitial or a rudimentary horn. Whenever it's a rudimentary horn, we will check whether it is a communicating or a non-communicating horn. But sometimes an eccentrically located gestation sac can be present either in a septate or in a biconjugate uterus. That is why you must check for the continuity with the cervix. So if you check for the continuity of the cervix, if it is inside one horn of the septate uterus, then it is fine. That's a true cornual pregnancy. You can identify if the G-sac is located at the lateral angle of the endometrial cavity, then it is an angular pregnancy. So look, you know how to handle a low-lying gestation sac. Now you also know if you see a G-sac somewhere eccentrically located, not in the midline, then what to do. See, now ultrasound is available in all the peripheral areas, in all the places. So judicious use of ultrasound. Once you feel something is wrong, once you feel there is a low-lying G-sac, then you can send to a tertiary referral unit, and you can really evaluate what is the true condition of the condition present, whether it is an eccentrically located G-sac or a low-lying G-sac. Now, a simple molar pregnancy. Again, will present with bleeding PV. And look, this is the classic snowstorm appearance in a complete mole. This is nowadays, because we are doing early pregnancy ultrasound, you are not completely getting that complete snowstorm appearance. Even earlier itself, you can identify this. Sometimes you can have your fetus inside, and you can have a big placenta. So whenever you have a big placenta and a small fetus inside, then you have to evaluate for a partial molar pregnancy. So to summarize, exercise extreme caution with regard to last menstrual period on history taking. Patients may forget their menstrual period, or sometimes the GSAC may not correspond to the LMP, but we always have to wait and watch. Visualize all of the uterus and don't neglect to scan the adnexa, because you can have a heterotopic pregnancy. You can have one inside the uterus and one in the adnexa. So you have to, whenever you do an early pregnancy scan, always see the uterus and the adnexa. Avoid labeling subchorionic bleeds as additional gestation sacs. We need to differentiate a twin gestation sac from a subchorionic bleed. Recognize molar pregnancy, pseudo sacs, and chorionic bumps. Missing an ectopic and misinterpreting a normal intrauterine pregnancy as an ectopic. Both can be avoided by meticulous scanning. That is why we need to know the criteria and the definitive usage of a good quality ultrasound. So the take-home message would be, woman presenting with bleeding PB and a low-lying gestation sac in early pregnancy needs a thorough ultrasound evaluation to arrive at a correct diagnosis. It is essential for every clinician to watch out for cesarean scar pregnancy in women who conceive after cesarean and actively involve the patient in decision making after discussing the available treatment modalities. Every time when you have whenever there is a previous LSES, it is ideal that she comes back for a routine ultrasound in the early pregnancy at 8 to 10 weeks, or a little earlier at 8 weeks, just to confirm that it is not a low-lying GSAC or a cesarean scar pregnancy. Ultrasound has an important role, and meticulous attention to the subtle markers helps to differentiate the benign conditions. A simple implantation bleeding, simple failed fetal growth, or a life-threatening one like a cesarean scar pregnancy or an interstitial pregnancy. Again, ultrasound has the key role. Thank you so much for your patient listening.
Thank
I'll
you,
just
Dr.
stop sharing.
Thank you for an excellent and extensive presentation. It was beautifully explained, the systematic ultrasound approach to early pregnancy bleeding and all the common diagnostic dilemmas, and as such, early pregnancy in total. Any questions from the attendees?
Yeah, I would be happy to take up the questions because I would be leaving now. So if
I
you
have
have
certain
any,
questions for you, ma'am.
great, Aisha, please go ahead.
Just basic questions. Can transvaginal scan be performed in early pregnancy bleeding? This is the major
Yes.
question everybody has.
Yes. See, the idea is a transvaginal ultrasound is even more safer than your PV examination, because actually ultrasound, when we do ultrasound, we are very cautious. We always do a transabdominal followed by a transvaginal, and sometimes transvaginal is important too for decision making. So after transabdominal, in transabdominal, if everything is clear, then you might miss. If you have a nice GSAC, you have seen the cord nova adnexa and everything clear, then you don't need a transvaginal. But under ambiguous conditions, doing a transvaginal is no harm in early pregnancy bleeding. We need to do it.
Can power Doppler be used in early pregnancy scanning?
No, no. You can, if you see the crown rump length, do not use color at all on it, because if it is a viable, the thermal energy will be more. So we always use when we don't see the embryo, or when you are very sure that it's a cesarean scar pregnancy, or you want to check for peritrophoblastic flow, all those only color power Doppler, not on the fetus. No, never. Always M mode for heart activity before 8 weeks.
Beta HCG versus ultrasound. It has to be in correlation only, or only that's it.
Yes, those are the two sides of a coin. You always have to correlate beta HCG with ultrasound. No single decision taken on one parameter. It's always beta HCG correlated with ultrasound. Yes.
Multiple early pregnancy scans, can they cause miscarriages?
Why do you need multiple early pregnancy scan?
Follow-ups in case they come in.
Avoid. If you have done it at 8 weeks, go for the NT scan.
Okay, ma'am. So a lot of likes and claps for you, ma'am. So
Thank
that
you.
was a lot of appreciation from the
Hello,
audience.
madam.
Yes, yes.
Hello. Apart from your local cause for bleeding, is there any possibility of generalized cause and infection or DAC? Is it a threat to your patient like this?
Aishwarya,
Any
obstetrician,
infection?
please. This is a question for you.
Infection or DAC?
Infection or DIC, sir?
DAC.
Any kind of not very much in early pregnancy.
Yeah. All of them are local
cause,
cause.
yes, fibroid adenomyosis, yes, but systemic
Generalized
causes are quite less, sir. Until and unless the patient is already a known case of DIC who's become pregnant or something similar to that.
Do you use local coagulate steps to stop this bleeding? Do you use any localized injection coagulants?
No, so oral tranexamic acid and progesterone. Local, no, sir. It is not recommended also.
Okay.
Any other questions?
Thank you. Any ultrasound feature to differentiate tubal abortion and ruptured ectopic?
See, the idea is you will have free fluid in both. Okay. A tubal abortion is like the whole thing slips out through the tube, and the other one is a rupture. By ultrasound, what you will see in both, you will see an inhomogeneous mass with some fluid around. Okay, that's how you will not be very clearly able to differentiate between the two because both will have the same pattern. Your management would be the same ideally because if you have lots of fluid in the pelvis, you once again need to intervene.
Any other? So we can't hear you.
Oh.
So we are not able to hear you.
Ultrasound probe transducer. Do you use any special transducer to pick up this bleeding?
Your routine probes are enough, sir. Your routine probes are enough. Yeah.
Okay.
In trans-abdominal patient full bladder, trans-vaginal empty bladder. That's all. The probe doesn't matter much.
Any other questions? Yeah, we are done. Thank you once again.
Ma'am, what will be the criteria for the cutoff of beta HCG in ectopic pregnancy? Is it below 2,500 or less than 1,500?
This 1,500 to 2,500 is a discriminatory zone. That is the time where we can be able to see the GSAC. For ectopic pregnancy, you need to wait. You may see the titers. Okay, your ultrasound image and beta C, that is a correlation. That the increase in titer will be less in ectopic pregnancy. You can't have a single cutoff value. Okay.
There's no doubling that you see in ectopic.
There's no doubling. That 1,500 to 2,500 is a discriminatory zone. In that zone only you will be able to see GSAC. Shouldn't confuse both. Thank you, everyone. Then thank you so much, Aishwarya, and thank you all, the delegates and the organizers. Thank you.
Okay, we now move on to our second scientific session, Doppler evaluation in fetal growth restriction, when to deliver. Fetal growth restriction, or FGR, remains one of the most challenging conditions in modern obstetrics. It is a major contributor to stillbirth, neonatal morbidity, and long-term neurodevelopmental impairment. The challenge lies not only in diagnosing FGR, but also in determining the optimal timing of delivery, balancing risks of prematurity and fetal hypoxia and IUD. Over the past 2 decades, fetal Doppler assessment has transformed the management of FGR. Evaluation of placenta fetal has become the cornerstone for surveillance and integral part of evidence-based clinical decision-making. It is now my pleasure to invite our next distinguished speaker, Dr. P. Devarajan sir, consultant in fetal medicine and interventional radiology at Netra Scans Fetal Medicine Center and Genetic Clinic, Tirupur. He is a distinguished member of National Academic Committee and course director of FTS Samrakshan, IRIA. He has several publications to his credit, including important research on third trimester Doppler, making him the ideal speaker for today's topic. Sir, it is a privilege to have you with us. I hand over the session to you.
Thank you. Am I audible, madam?
Yes, sir.
Okay, just a minute. I'll share my screen. Yeah. You able to see my screen?
Yes, sir.
Yes, yes. Okay, okay. Okay. At outset, I thank the organizing team of TN Amscon 2026 for giving me the opportunity. It's a wonderful effort putting all the specialities together under one roof. Thank you for the opportunity. So we will go about the next session, the Doppler evaluation of fetal growth restriction, when to deliver. FGR, when to deliver, is still the subject of great controversy in practice. However, we will try our best to deal how effectively with available evidences and experience. So if you look at the Indian scenario, we have large number of pregnancies annually, about 28 million pregnancies, as well as we have a large number of adverse pregnancy outcomes, like 1 million neonatal death and the 7.5 lakhs of perinatal death, large infant mortality rate, and also 67,000 of approximately the maternal deaths annually. So India has highest number of stillbirths in the world. The stillbirth refers to the death of fetus after 28 weeks of pregnancy, but before birth. And large proportion of stillbirth is due to undiagnosed FGR, as per the statistics, not as we thought. It is not idiopathy. If you look at the relative prevalence of adverse pregnancy outcomes in India, the low birth weight is most common. It's up to 30% of pregnancies in some regions, and also the next is the hypertensive disorders in pregnancy, 10 to 12%, and preeclampsia accounts for 8 to 10%. And moreover, we are having the maternal mortality rate of 13 per 10,000 live births. That means we are losing more than one mother for every 1,000 pregnancy. So even the Down syndrome incidence is even more than the Down syndrome incidence. The Down syndrome occurs around 1 in 1,000, but we are losing more than one mother. We are doing all the meticulous work for all these things. That is the anomaly scan, anti-scan, everything. It's important. I'm not saying it's not important, but it's individual pregnancy related. But when it's come to the community, we have large magnitude of problems like preeclampsia, fetal growth restriction, large proportion. And are we concerning about this first? Yes, we have to concern that. We have to focus our attention for this. And it's the obstetric Doppler. If we meticulously apply at various levels, we can predict, prevent, and timely manage and reduce all sort of these complications. So this is the Samrakshan, that's a program of Indian Radiology Association. It's come up with targeting the perinatal mortality in India. We have trained a lot of radiologists for this regarding the perfect management of with obstetric Doppler. And I was one of the course director and author of this, and this is the first paper we published. Me and our team has published. It was rational for universal first time screening to identify pregnant women at risk of preeclampsia. So actually, the preeclampsia and FGR shares same pathophysiology in more aspects, and also the etiological aspects. So in some areas, I will be talking together. I will not discriminate between preeclampsia and early FGR. So if you look at the fetal growth restriction, FGR is defined as a failure to achieve the enormous growth potential, and with EFW, estimated fetal weight per abdominal circumference less than 10% with associated Doppler changes. So if you look at all perinatal morbidity and mortality and neonatal complications will be 10 times more in babies suffering fetal growth restriction. What are the etiology for FGR? We know it could be a maternal factor like hypoxemia, chronic disease, anemia in the mother, smoking, etc. And the more important placental factors, abnormal placentation and post-placental factors like umbilical cord issues, the increased coiling, then single umbilical artery, filamentous insertion, so many things. And next could be a fetal cause, a genetic disorders, a structural anomaly, or congenital infections of fetus. So all these things. But if you look at the prevalence, the most common cause will be placental insufficiency, that is abnormal placentation. It accounts for about 80%. And how the abnormal placentation causes all these things. So if you look at the normal placenta, the terminal spiral arteries that's coming, the crossing the endomyometrial junction, supplying the endometrium, in turn it's supplying the decidua, that is the placenta after the pregnancy happens. So the terminal spiral arteries, once the pregnancy happens, these trophoblastic cells will come and invade the walls of spiral arteries and destroys its smooth muscle layer, so that without smooth muscle layer to contract, the terminal arteries will dilate enormously and give the large pool of blood into the placenta as well as fetus. So there is the normal remodeling of spiral arteries. But what happens in abnormal placentation that going to cause your preeclampsia or early SGR is this spiral artery remodeling does not happen properly. That means the trophoblastic cells will not invade the spiral arteries. So the spiral arteries will be persist as pre-pregnant stage small caliber vessels with high resistance stage. So this will not dilate enormously and will not allow adequate blood to the placenta, leading to placental ischemia. That is the cause for preeclampsia as well as associated early onset fetal growth restriction. So overview of Doppler in fetal growth restriction. In the first trimester, it's Doppler as start with prophylactic treatment with low dose aspirin. In the second trimester, again, uterine aortic Doppler is cornerstone for deciding monitoring. And third trimester, our role is to early diagnose FGR, stage it, follow it, and timely deliver. So for that, we need to do all Dopplers, that is umbilical artery, MCA, ductus, and aortic isthmus, etc. So we will see each a little bit detail. So what is the inverted pyramid of antenatal care? It's put forward by the father of fetal medicine, that is Kypros Nicolaides, a decade back. So in the modern obstetrics, we are now in the era of inverted pyramid of antenatal care. First one is traditional pyramid of care, in which our care and attention, number of antenatal visits, focus is more towards the later in gestation, that is towards late second and third trimester. This is because most of the complications are manifesting towards the third trimester and towards a term. And this is but we are chasing the complications after it's occurring. This is the mode of the pyramidal care for many decades. By that, we have not changed. We have not improved any outcome in respect to the prevalence. So, what is the modern obstetric is now? The pyramid of care is inverted. The first trimester, that's 12 to 13 weeks, is the prime focus. We have to divide the entire pregnancy population into high risk and low risk group. And high risk group should be applied the adequate intervention. That's to intervene before the complication occurs. That is our aim. That then only we can the prevent. It's the whatever FGR or preeclampsia, whatever happens in the future, that you can prevent and you can curtail its occurrence. So the first trimester, 11 to 13 week scan becomes the crucial in modern obstetrics. It's not just another scan, just like making an NT measurement. It's not like that. We have to do the entire screening. This is a roadmap for entire pregnancy. Is your first trimester scan. That's respect to aneuploidy screening, respect to anatomical survey, the anomalies, the respect to cardiac evaluation, the preeclampsia and FGR screening for preterm delivery, JDM. So every screening should be applied meticulously and properly at this gestation period at 11 to 13 week scan. And by this roadmap only, we are going to foresee and intervene what is necessary for the entire pregnancy that's going to happen. So in this so the parents also will not nowadays we cannot accept surprises later in pregnancy. Even the parents will not accept the shocking news like there is an UD or an abnormal the FGR which going to need, there is an eclampsia. So all these things should be screened properly in NT scan during 12 to 13 week scan. So we also should focus on this. The parents also, let the parents spend more for this. Let the parents come more visit for this. So this is crucial. As a part of this, we do a combined preeclampsia screening. As per the FMF algorithm, the preeclampsia screening and preeclampsia also, this is also a part of early onset FGR screening, the same. So we need to take it with 4 steps, that is maternal history, height, weight measurement, that is the clinical parameters, and measurement of mean artery pressure and measurement of uterine artery Doppler, PI, and in affordable cases you have to measure PLGF, PAPA, that biochemical markers also. So with first 3 steps alone, we can detect up to 70 to 80% of preeclampsias that is happening in preterm preeclampsia and associated fetal growth restriction. So if we add the biochemical markers, the detection rate goes up to 90%. So we should apply all these steps, at least these first 3 steps. If the patient is not affordable for biochemical markers, these 3 steps we can apply. Anyhow, we have to take a clinical history perfectly and do and mean artery pressure with the BP apparatus, automated BP apparatus is enough, and uterine artery Doppler, PI. If you do it perfectly, this itself is the best prediction tool and screening tool up to for 70 to 80% of prediction. So we know the history. What are the things that will cause FGR or preeclampsia that we have to ask, including the you have to look at the serum markers, mean arterial pressure. We have to use the automated devices on both sides simultaneously. The woman should be in sitting position and their legs should not be crossed. The arm should be supported at the heart level. The adult cup should be used, and after rest, 2 measurements should be taken 1 minute interval, and reading should be recorded in the software for calculation of risk. Step 3 is uterine artery Doppler PI at 11 to 14 weeks. So normal the uterine artery Doppler usually the uterine arteries will enter into the uterine contour at the level of cervicoischemic junction and divides into multiple branches. So you have to just look at the cervix first. Then you put the color box and tilt your transducer towards either side of cervix to get the main uterine artery. Sample gate should be 10 2 mm. Angle should be kept less than 30 degree. PSV should be more than 60 centimeter in sampled uterine arteries. That means it is main uterine artery. So if you are not getting uterine arteries abdomen, always you go for transvaginal scan, and it's the same time you measure the cervical length for cervical screening, and by the time you just look at the uterine arteries on either side of cervix, get the perfect waveform for uterine arteries. This is more crucial for screening. So what happens to uterine artery Doppler in preeclampsia and as well as early onset FGR? As I said, in the normal remodeling, spiral artery remodeling, because of the large blood flow to the spiral arteries and to the uterus, what happens is the pre-pregnant high resistant state uterine artery Doppler waveform will become low resistant high diastolic flow pattern like this during the second trimester. It starts from the first trimester itself, this change, and during the second trimester you will achieve this the sort of waveforms. This is normal. But what happens in preeclampsia and early FGR, this high resistant pre-pregnant stage high resistant uterine artery flow pattern will persist in the first trimester as well as in second trimester, also continues later in pregnancy. This means it is abnormal uterine artery. That means abnormal placentation. It's giving rise to the complications like early FGR or preeclampsia. So there is nomogram for the uterine artery Doppler for entire pregnancy that's available in ISUG. So we have to do on both sides. The average PI you have to take if it is falling more than 95th percentile for that gestation period, we call it as high resistant flow. Early diastolic notch is not used now, but however, if the early diastolic notch is there, it is already represented in your PI. PI will be very high. So once we do all these three steps, you have to calculate patient-specific risk for preeclampsia and FGR. That will be done in FMF calculator. It is available free of cost. You can use it, so you can get the risk. How do you interpret the risk? The 150 is cut off. If it is more than 1 in 150, this patient or high risk for both preeclampsia or early FGR, you have to start them with low dose aspirin. That should be taken at bedtime. From 12 to 36 weeks will reduce the risk of preterm preeclampsia as well as associated fetal growth restriction up to 70 to 80%. And low risk group can be reassured and only just asked to come for anomaly scan. In mid-trimester anomaly scan, what do you do? There is a checklist for FGR. So first thing is detailed anatomical survey. You have to look for all structural anomalies, soft markers, and disorders of fluid. Either oligo is there, everything. And then main thing is uterine Doppler. You have to do perfectly, get the pulse PI index, and if it is more than 95th percentile, that is a high risk. That means these pregnancies can face fetal growth gestation later. Then presence of marginal or velamentous cord incision, two vessel cord, single umbilical artery, abnormal placenta morphology like thick and calcified placenta. So all these things are clues that may have this may proceed for fetal growth restriction. And another thing is decreased fetal growth velocity. If AC or EFW below 10th percentile or fall off more than 50th percentile between two consecutive scans, then we have to do fetal Doppler also, umbilical and MCA Doppler also during the anomaly scan itself. So how will you do uterine Doppler in second trimester? So from the midline of maternal abdomen, you just slide your probe towards laterally, you will see the iliac vessels, and uterine artery will be seen as crossing of iliac vessels. So you just apply the pulse wave Doppler, you will get the uterine artery waveforms. So if at the end of anomaly scan in the report, if you see high risk factors in anomaly scan, for example, the uterine artery showing high risk, or the single umbilical artery, or some the placenta is thick, so many things, as I mentioned. If it is so, make sure that first step is make sure that high risk group is started on aspirin and taking it regularly. Then the intensive ultrasound Doppler monitoring for FGR every 3 to 4 weeks, and require regular monitoring by BP and urinalysis for preeclampsia. So this may happen, so we have to attend closely. And if FGR is diagnosed with Doppler changes at 20 to 24 weeks, means we have to do genetic evaluation also in term of either QF-PCR with karyotyping or chromosomal microarray, particularly if severe FGR happens before 24 weeks. And also evaluation for congenital infection, TORS PCR, if there is this clue for fetal infection like placentomegaly, that small head circumference, ventriculomegaly, calcifications, or echogenic bowel hydras, etc., then you have to screen for infection also. And so now we move on to third trimester. Protocol for third trimester scan in FGR. The first thing is assessment of growth. The growth for assessment, you should know the starting point. Decide the gestational age from the dating scan. So just before you keep the probe for growth scan, you know the gestational age by dating scan. Don't give a biometry derived gestational scan as age in the growth scan. That is very wrong way, because once you assign the gestational age at the early pregnancy, that should be continued forever. And you should start the starting point of the scan is the dating scan. From there, you have to derive, and you do a perfect biometry, plot the percentage chart. Then the assessment of Likert by either 4-quadrant AFI or single depth positive method. Then you do an anatomical survey, because there may be an evolving anomalies over the period after second trimester, or there may be an overlooked anomalies. So you should do an anatomical survey. Then you do a perfect Doppler of uterine arteries, umbilical arteries, MCA in all cases, and ductus and aortic isthmus only in severe IUG established cases. Then serial scans for growth not less than 2 weeks interval. So this is how we do the perfect biometry as per the caliber placement. It's not, you should not adjust it as per your gestational age. Okay, you do a perfect biometry and apply biometry in growth chart. That is ideally local or regional growth charts should be applied because if you use the Western charts, it may show you an FGR baby because the Indian babies are small as compared to West. So ideal in Tamil Nadu, we have the Suresh source, the Mediscan chart is available. That's best represents the Tamil Nadu population. And also there are regional charts available, we can use it. So if the growth trajectory is falling below this fifth percentile line, you should always suspect there is the growth lag and it could be an FGR. We have to do a Doppler, the perfect Doppler. What are the Dopplers you will do? You will do all the Dopplers, that is the diagnostic marker like uterine artery Doppler, umbilical and MCA. This should be done in every case because based on this only we are going to diagnose it. And the ductus venosus and iaticus, when established cases of FGR, we can do this. So how will you do umbilical artery Doppler? So just first do a survey scan and identify a free floating umbilical cord, then put the color box. Pulse wave Doppler, you just apply over the middle of the umbilical cord. It's easy to get an umbilical artery Doppler. Anyone can do umbilical artery Doppler very easily. Then one thing is avoid during active fetal movement and fetal breathing because it's abnormally the waveforms may be altered. So the normal umbilical artery Doppler waveform usually it's low resistant flow. So throughout the gestation it is low impedance flow. And even its impedance will keep, that is, the PI will become low during the course of the pregnancy. But what happens in fetal growth restriction? So this normal, the low impedance flow of umbilical artery as the gestation advances in fetal growth restriction will give rise to your high resistant flow, then the absent in diastolic flow. The diastolic flow will touch the baseline and then it's reversed. It is the final stage. So this is how it's progress. And next is the middle cerebral artery. How will you get it? Just take a transverse view of fetal brain at the level of BPD. That's we take it for BPD plane. From there, you just slide the transducer towards the base of skull with the color box. You will see the circle of Willis. The middle one is the middle cerebral artery. So you just take the pulse wave Doppler from the middle of the vessels. Avoid the pressure in the probe so that the waveforms will not be abnormally altered. So abnormal MCA Doppler is, we call it as brain sparing effort because the MCA informs about existence of brain vasodilatation in fetus. That is a surrogate marker of hypoxia, fetal hypoxia. In response to fetal hypoxia, the vasodilatation happens in vital organs like brain, heart, and adrenals so that the blood is shifted to these organs that we are identifying in MCA Doppler as the low resistant flow. So the high resistant normal flow will become low resistant flow because of vasodilatation. So there is nomogram for entire pregnancy. Usually the MCA Doppler, the PI will be around the 2 to 1.5, but if it is going below means it is vasodilatation. So ductus venosus Doppler is in established cases, we have to do ductus venosus Doppler. It's the mid-sagittal longitudinal section of fetal trunk. You have to apply color box. You will see an aliasing. There is umbilical portal vein joining at the IVC. This is the portion of ductus. You have to get the waveform with the smallest caliber, smallest gate size. So abnormal ductus venosus means there is very high risk for stillbirth within 3 to 7 days. So perinatal mortality ranges from 40 to 70% in early onset of GR. So this is the normal ductus venosus waveform with good S and D, the positive, and A will be dip. This is the normal wave pattern. If A wave is close to the baseline, this is abnormal, this is high resistant. If it is reverse, that is critical, that is the final stage. So aortic isthmus is the vessel in severe FGR due to hypoxia. The severe cerebral vasodilatation shifts entire blood to the brain. So in this flow, in this course, the aortic flow also shifted to the brain. That's how the isthmic region of aorta should never be should show negative flow in Doppler in the fetus. But in case of severe FGR, even in the aortic isthmus will shift. This should show the negative flow. That means there is reversal of flow in aortic isthmus. That this indicates the advanced deterioration, the fetal deterioration, aortic isthmus reversal precedes ductus venosus abnormalities by 1 week. That means it's dangerous. It's alarming sign. So we'll see the fetal growth patterns. Normally, if EFW or abdomen circumference is 10 to 95th percentile, that means appropriate for gestational age. If we call this as decreased when it is below 10th percentile, that could be due to physiological, small for gestational age, or pathological fetal growth restriction. If it is increased more than 95th percentile, this is large for gestational age, example in GDM, others, etc. So if FGR is less than 10th percentile means, how will you differentiate between the either it is FGR or small for gestational age? So FGR is equal to EFW of less than 10th percentile plus any of these three. Either uterine artery PA is more than 95th percentile, or CPR, cerebroplasmal ratio, is less than 5th percentile, or EFW, the estimated fetal weight, is less than 3rd percentile. The very low expected fetal weight. So in these three is met, then we call it as fetal growth restriction. It's no more SGA. The previous dictum of only abnormal umbilical artery Doppler to say fetal growth restriction is not used anymore. So now the criteria is these three. So how will you actually we different there are two types we categorize fetal growth restriction: early onset when it occurs before 32 weeks, late onset if it occurs after 32 weeks. There are a few key differences between these two. The prevalence is more for late onset FGR, 70%. But it is actually, we are not seeing much of late onset FGR because the diagnosing will be very much challenged in late onset FGR. Detection itself is a challenge. The early onset FGR, it accounts for 30% of the prevalence, but we are seeing more number of early onset FGR only because diagnosing will be easy, but managing will be difficult in these cases because the associated placental pathologies, the associated preeclampsia, everything is more in early onset FGR. Late onset FGR, actually it lacks particular natural history with low morbidity and mortality. So we have the cascade of events happening consequently and step by step in early onset FGR. So we saw in the first trimester itself, we can see uterine artery PA more than 95th percentile. Then next step happens is CPR will be falling below 5th percentile. Even in second trimester it happens, and after that the umbilical artery will go high resistant, then MCAPA will go down. So once umbilical artery going high resistant, then within if it progress to next stage, averagely in a week period it may go for absent end-diastolic flow. From there, in a week period it may go for reversed end-diastolic flow. So next is will be your ductus venosus abnormality. After reversal of umbilical artery Doppler, we see a ductus venosus waveform will go reversal of A wave. Then followed by your CTG changes and biophysical profile changes with either intrauterine fetal demise or serious brain injury happens at the end stage. So in late onset FGR, this cascade will not happen as like we see it is after 32 weeks. Sometimes up to 32 weeks, fetus grows well. Only the mild placental insufficiency there. But after 32 weeks, once the fetus attains certain weight, that's it's available, the resource that is the fetal placental reserve is, even though it's mildly less, but the fetus is grown now, it is not adequate for this fetus, the 32 weeks fetus. So what happens is, the fetus, the hypoxia in the fetus actually responds in different way in each fetus. Actually, you will not see umbilical artery abnormalities in late onset FGR because the umbilical arteries are normal since the placental disease is low, but middle cerebral artery may show abnormality. It may show in 25% of cases, it may show low resistant flow because of vasodilatation, because of response to hypoxia. Uterine RTPA may show abnormal, there is high resistant flow, and CPR may be low, but it's not the mandatory. It may be there, or sometimes it may not be there. So, but what happens is, if we allow this late onset FGR fetus to the term, there may be an acute deterioration because of towards the term there will be more uterine contractions, and particularly in second stage labor, if we allow for normal vaginal delivery, sometimes there may be deterioration during the fetal distress. So always be careful about late onset fetal FGR. And how will you classify as per the Doppler, the fetal growth restriction? So this is as per the Grattakos and Figures classification. Stage 1 is mild changes. Either CPR is less, or uterine RTPA or MCA, any single vessel is abnormal, then it's low, it is the stage 1. And stage 2 is absent end-diastolic flow in umbilical artery. The stage 3 is reversal of end-diastolic flow in umbilical artery. Stage 4 is ductus venosus A wave reversal. So this is the high risk of death, and stage 3 is suspicion of acidosis. So timing of delivery, the stage 1 means it is the severe smallness or mild placental insufficiency. As I said, in the stage 1 FGR, the monitoring should be weekly. Every week we have to monitor with fetal Doppler, and deliver by 37 weeks by labor induction. That is, if it is not progressed to the stage 2. You have to monitor closely. If persist in stage 1, then we can extend up to 37 weeks. Stage 2, that is absent end-diastolic flow in umbilical artery, means we have to monitor twice weekly by the Doppler. We have to look for whether this is going for next stage, that is reversal is happening or not. If reversal is not happening, then we can extend up to 34 weeks. Why we are fixing 34 weeks or 37 weeks? Because this is the arbitrary cutoff derived by a lot of research, that if we extend beyond 34 weeks in stage 2 IUGR, the chance of IUD is high. The risk of IUD overcomes your risk of prematurity. If we deliver it before 34, for example, if we deliver because of absence, just can we deliver 30 weeks, 32 weeks? No, because we are inducing prematurity related complications in this fetus. So that also should be, you should not overact also. We have to, this is the appropriate cutoff as per the studies, that you can extend up to 34 weeks and you have to better deliver by cesarean section, because of the complications that the fetal the distress can happen if you allow it for normal vaginal delivery. In stage 3, if reversal of umbilical artery is there, then we have to follow it of thrice weekly. The stage 3, remember the thrice weekly. Stage 2, twice weekly, follow with Doppler. And we should not allow beyond 30 weeks in stage 3 in the reversal. So if it happens after 30 weeks, in any point of time you have to deliver. You should not wait for next stage. So because after 30 weeks, the mortality will be high. That is, IUD may happen anytime if we allow it in utero. So, but before 30 weeks, if it happens at 28 weeks, we can allow with close monitoring up to 30 weeks. If stage 4, irrespective of that is after 26 weeks, you have to deliver immediately at any point of time, because high risk of fetal death and acidosis, and even all neuronal complications will happen. So as per the FIGOS, the recommendations. So first is SGA Doppler. The FOXY recommendations. The first one is SGA, small for gestational age with normal fluid and Doppler, deliver at 37 to 39 weeks. Mode of delivery will be induction. And uncomplicated FGR, that is normal fluid, normal Doppler studies, but the estimated fetal weight is less than 30%. In these cases, we can deliver from 37 to 38 weeks. The mode of delivery will be induction. And the next, if FGR with mild abnormalities, like mild changes, like CPR is less, uterine PA is high or MCA, all these things are oligohydronis is there. So any mild form of abnormality, the delivery window will be 34 to 37 weeks. That means we should not also deliver before 34 weeks and we should not extend beyond 37 weeks because even though it's mild change, but there may be adverse outcome if you allow it after 37 weeks. So mode of delivery, as per the Western literature, it's cesarean section, or you can the Foxy recommends or induction also. But ideally, the cesarean section will be optimum. And if it is absent or end-diastolic flow or reverse end-diastolic flow, absent end-diastolic flow 32 to 34 weeks, reverse 30 to 32 weeks as per Foxy. And
Devarajan sir, sorry
yes,
for
sir, yes.
interrupting, sir. Sir, we have
Yes, sir.
4 more speakers, sir. Kindly
yes,
stick
sir,
on to the
yes.
time, sir. Yes, sir.
Sure,
Yes,
sure, sure,
please.
sure. Yes, sir, yes, sir. So you conclude it, sir. It's last slide actually. Okay, sir. Okay, thank you. FGR with abnormal ductus venosus, we have to deliver immediately after 26 weeks. Thank you for the patient listening. We are just concluding with the when to deliver. So that's the key take-home message is first screen properly in the first trimester itself and meticulously apply Doppler at every step to diagnose early and deliver as per the Doppler staging. Thank you very much.
Thank you, sir. Thank you, sir.
Dr. Devarajan, sir, for an
Madam,
excellent presentation. We will. So there's just
we
one
can
question.
have the questions at the end, madam. Delegates can post the questions in the chat box so that we can discuss in the end.
Okay, okay, sir.
Due to time constraints.
So,
Thank you, madam.
going further to the next session, which is about breast cancer, and it will be moderated by Dr. A. Prabhakar, sir, Professor of General Surgery, Chettinad Medical College. Handing over to you, sir.
Madam, our next topic, I think, imaging of breast cancer is there, no?
Yes, sir. Dr. Prabhakar, sir, will be taking over the moderation.
Taking over the, yes, madam. Thank you,
Yes,
madam.
yes.
Thank you.
Correct, sir. So, Prabhakar sir, you can take over, sir. So, the first topic will be on imaging options in breast cancer diagnosis by Dr. Bhavna. She is a professor in radiology from Sri Ramachandra Institute, Chennai, Porur. And we have the second topic will be on surgical management, third will be on medical management, and fourth will be on radiation management of breast cancers. Over to Dr. Prabhakar sir and Dr. Bhavna madam, you can start the presentation, madam.
Before that, Dr. Bhavna madam, breast carcinoma is the leading cause of death in many countries. From radical mastectomy, the surgical management has evolved into the breast conservative surgery recently. Medical management has evolved into targeted therapy recently. Radiation therapy has also evolved into various types of radiotherapy in which we can give radiotherapy for a few weeks or a few days only. Previously, it was given for 6 weeks period. So all the recent advances in the surgical management, medical management of the breast carcinoma, and the recent advances in radiotherapy of breast carcinoma will be discussed in details by the speakers in the following 2 hours period. I want to welcome all the speakers to this online clinical session on carcinoma of breast. Now I invite Dr. Bhavna, professor and lead consultant breast imaging and interventions in the Department of Radiology, Sri Ramachandra Institute of Higher Education of Research and Research, Porur, Chennai. Madam, over to you.
Thank you, sir. Thank you for this kind introduction, and thank you IMA for having me here today. Without wasting our time, we'll go to imaging options in breast cancer. So we all of us are very much aware that the breast cancer has become the most leading cause of cancer in India as well as abroad, and this will be discussed later also. So I just want to go to imaging more than this. So facts are there are certain facts which we should remember that incidence increase with the age, but age shift has been noted. Now more of younger women are being affected by this cancer, and we should remember that in younger women this is more aggressive. So basically all women are at risk. Initially, we used to think that it will come only at the age of 60, 50, above that, but now we are seeing more and more younger girls to have this, and both cancers are more dangerous as compared to the other, when it comes to the other ladies. So the 5-year survival rate is in US, it's nearly 90%, whereas as compared to India, it is only 60%. Why is that so? Because we pick up the cancers at stage 4 and stage 3. The patients do not come to us. We do not have a screening program. Okay, we have an opportunistic screening. So we usually see in our daily practice, we see patients like this, with the pudgy orange parents with, you can see this, the nipple retraction and pudgy orange hair. You can see this Paget's like how, and I mean, the patients when they come, they are really, really blown out cancers. They are at stage 3 and stage 4 because they really don't care about it. So what can we do then to find the cancer early, and how we can help the patients? Okay, so the main agenda of all these lectures and everybody's today is that we should find it early so that we can treat it early. So the ways to find the early cancer is either you do a breast self-examination, clinical breast examination, and imaging, which is the mammogram being the workhorse. So when a patient does a self-examination, okay, if you are lucky enough, you might find, and the patient is examining herself very well, so she might find a cancer. Otherwise, most of the times, when the cancers become lemon size, they start seeing it, or they become peanut size. When the patient goes to the clinical examination, you have a opened up peanut, that size cancer you can find. But when the patient comes to radiology, when they come as a screening patient, we can find the cancers which are pepper size or a sand particle size. So in today's era, we don't want to find a cancer when it has come to this size or it has come to this size. We want to find the cancers which are not palpable, which are less than 1 centimeter, and where you have a very, very good way of treatment. You can be treated very well, and you can be treated fully radically. So screening mammogram is a mammogram which is taken to check the breast before any cancers or signs of symptoms have come. And diagnostic mammogram is when a doctor has palpated or a patient is feeling something, and the patient comes to us for diagnosis that what type of a lesion it is. So basically, the way to go is we need to do a screening mammogram. So why is screening important is, again, as I told you, the outcomes are really strong. Okay, it is stage dependent. When we find it at an early stage, they are node negative, they are smaller cancers. And image-based screening is a principal tool of shifting and detecting it early. Okay, if we do X-ray mammogram, I'll show you how we can find the cancers as early as possible. And then we have a standard language, okay, standard lexicon called BI-RADS, which is, very much convertible, which if I write my report as BI-RADS 3, my surgeon or my medicine person should agree, or they should understand that this is what is going to be the stage of the cancer. So structured screening framework is whom we should do. Okay, what is for whom, which people, which ladies we should do an X-ray mammogram, when it should be done, and why it should be done, and what does it detect. So four W's are there. Whom to screen? Average risk woman. So as I told you in my first place, every woman is at risk. Okay. So above 40, we need to do a screening mammogram for all the ladies. Okay. High risk women, which are BRCA1 positive and other pathogenic mutations are there, and they have a history of radiation priorly, they should start the mammogram at the age of 30. And also it is said that, if suppose your mother had got a cancer at 40 or at 42, you should start screening yourself 10 years earlier to what age they got the cancer. So intermediate risk and dense breast, when you see when you have done a local mammogram, okay, a routine mammogram, and you see a very dense breast, and you see some kind of a lesion which are like, intermediate kind of a lesions, those ladies are also at risk. And obviously the diagnostic mammograms are done for the symptomatic patients. So now when to start the mammogram? Okay, average risk women, which is every woman, okay, should start at the age of 40 to 45 years. And high risk women should at least start by the age of 30 years. And as I said, 10 years before the youngest affected relative. And what is the interval when you should do? Lot of women, okay, even I'm telling you, educated women, which we see, urban ladies, okay, they say that, they all think that, okay, yeah, once my mammogram is normal, it's going to be normal throughout my life. It's not that. We need to do an annual screening, because it does not mean if you don't have a cancer today, you won't get it tomorrow. But the best thing is to prevent, and how to prevent, to do an annual X-ray mammograms. And what is the stoppages? When can you stop? There is no age defined to stop the mammograms. As far as you are healthy, you can keep taking them. And why do we screen the breast? Because obviously it will decrease the mortality. Once you find the cancer at an early stage, you can treat it earlier and you can reduce the mortality. Obviously, you can downstage it and reduce the treatment burden. Now, what modality to use? Okay, now everybody knows that mammography is there, ultrasound is there, MR is there, and now a new, kid on the block is contrast enhanced mammogram, which is a poor man's MRI. So mammography basically is the first line of screening. Every woman at the age of 40 and above should do mammogram. Ultrasound is done usually as a problem solving or as a supplemental technique after the age of 40. It can be done in any age. MRI is the most and CM is the emerging alternative functional modality, which can be done nowadays. So mammography, the screening workhorse, finds 70 to 85% of the breast cancer. Still, it misses 30% of the cancers in a dense breast. So we can add on ultrasound. So as you can see in these 4 images, as we grow older, this is the youngest woman, extremely dense breast. So if something is hidden under this, we can still miss it. Something is hidden under this, we can still miss it. But as you grow older, you have a fatty breast, it's very clear. Okay, that is one of the reasons why before 40 ultrasound is done, because you will have an extremely dense breast. But now we have something called tomosynthesis, okay, which is like a CT scan. Okay, it is a slice by slice, you see your breast. Okay, so this is a very easy analogy to show you. If you see a mammogram, it's like a loaf of bread. When you do a tomosynthesis, it's like cuts into slices, like a slices of the bread, and you can see the smallest to the smallest lesion within the slices. These slices are, approximately 1 to 1 millimeter, so that you do not miss even the smallest cancers. So we have actually, as in the beginning of the session, doctor was telling that no, we have all advanced in surgical management, medical management, radiotherapy. So is in radiology also. We have gone far, very far, and we can detect the smallest to the smallest cancers. So this is how the pictures, multiple slices come. Okay, and this is within the radiation limits. Okay, these are low dose images which we get. Okay, the tube moves around the patient like this and then takes the images. So this is one patient, you can see, okay, very clearly, you can see very dense breast. Somebody will say, okay, there is something like that. But when you do a tomosynthesis, if you see this video, you can see here, there is a cancer sitting here and it is very cleanly seen. See, there are some tentacles and all that. So this is how beautifully the tomosynthesis shows us the cancer. Not only it shows us that it is a cancer, it will show us the exact extent that the cancer is extending, in this case, from here to here. So the extension of the cancer also you can see. If you can see, multiple cancers are there and you can very well define cancer. Like similarly in this case, if you see, this is a dense breast, this is a 2D image, this is a 3D image. When we do a video for this patient, the video is running, you can see slowly it is running. You can see here, see how it's like a crab like. Okay, you can see that there's a cancer, the nidus of the cancer is sitting, it's gone extension up till the pectoralis muscle and going up to the nipple. Okay, so it is showing cancer beautifully. It won't miss the cancer, and also the extension, which will actually lead to the treatment options for the surgeon, that what kind of a treatment would be appropriate for this patient. For example, this patient, see now, if you see, there's another nidus sitting here, so she has a multifocal cancer. Okay, so there are 2 cancers there. So this is the advantage of tomosynthesis. Now there's, as I was telling you, this is a new kid on the block, contrast enhanced mammogram. So this is a very simple technique. It's done under the same machine mammogram. So you inject the contrast, similar contrast as we give it in CT patients, and then we will acquire the images which are called subtracted images like angiogram. You guys have all would have seen it, angiogram. So it will just subtract everything else, the background parenchyma and everything, and it will only show you the lesion. So you can see that there is only one cancer here. So it tells that this patient is a appropriate patient for the breast conservative surgery. There is no other lesion in this breast or in the other breast. So this is how quickly it is done within 5 minutes, and we can give the report, and you can see the images are very much reproducible. Even the surgeons love it. They just see it and they can interpret it clearly. Another case, if you see it just like that, if you don't have a history, you have not done a clinical examination, you will say you can pass it off as a normal. But when you do contrast, you can see the entire breast. Okay, it is multifocal, multicentric. You can see it is in multiple, multiple quadrants of the breast. The cancer is here. This is cancer. This entire thing is a cancer. This is a focus of cancer here, here you can see. So the contrast enhancement mammogram is a very good technique. It can be done within 5 minutes in the same mammogram suite, and the results are very much reproducible, and the surgeons can also interpret it very nicely. You can see even the lymph nodes are also affected. So this is one case, as sir was telling, everything is now very methodical, everything has gone thing. So this is a very practical case and a significance of CM. So 50-year-old, she came with a breast lump for 3 weeks, and you can see very clearly on 2D, there is a lump here. The patient want to go for a BCS. Okay, so we did ultrasound. We found that this is the mass and this are her lymph nodes. So we did a contrast exam. You can see only this mass is enhancing and the lymph nodes are also enhancing. After that, we had done a clipping for this patient. Okay, after the biopsy, this is a PET scan showing a mass and the PET positive nodes. So clip insertion was done in the mass as well as in the node. So you can see a clip here. Okay, so patient underwent after that 8 cycles of neoadjuvant chemotherapy, and you can see after the NACT, totally, entirely the mass has vanished. So this is the clip which will help the surgeon to go and get to this place, and the surgeon will operate. So this was the mass before pre-chemo, pre-NACT, and this is post-NACT. You can see it, and totally there is no enhancement after the treatment. You can see pre and post for comparison. And then we did a wire for this patient. Okay, we just followed this clip and did a wire. You can see the wire and clip together. We sent this patient image to the surgeon. They operated it and they sent us the excisional biopsy specimen. You can see both have come out, the clip as well as the wire, and the margins are also clear. So this is how the cases are worked up nowadays, and you become very clear, that whatever you are doing it in a proper fashion, and this is how you can actually benefit the patients. Now coming to the breast ultrasound, it is a first imaging choice in a ladies less than 40 years. Okay, and it is the best modality to see the axilla. But remember, it cannot replace X-ray mammogram. Lot of ladies, they come and they say, we'll just do ultrasound. Lot of consultants, they refer the patient for ultrasound. They say, patient is telling that we'll have a pain, this and that. But nowadays, the machines are so sophisticated, the compression is done only and only for 6 to 10 seconds. So one compression for 6 to 10 seconds, I think it's worth taking the pain when you want to find the earliest of the earliest cancers. So there's similarly, like, as we are doing contrast enhanced mammograms, there is a contrast enhanced ultrasound also. So if the patient is a renal failure patient and so forth, you cannot do a contrast into the patient. You can use contrast enhanced ultrasound. So there is a agent, these are the agents which are microbubbles, which we inject intravenously, and then we follow the contrast. Okay, like in other organs, you can see that this is a lesion here, and we have seen the lesion is getting filled up. So it says that it is a positive lesion. Similarly, here you can see a node, which is round node. And when we give contrast, it is just filling up and quickly it is washing out. So again, it indicates that it is a malignant lesion. Elastography is also a very wonderful tool. It is very much available in ultrasound machines. Now what happens is, now we have again gone into precise medicine. Okay, so when we do elastography, when we turn on the elastography will tell us which is the hardest part of the mass. Okay, it will first tell us whether it is, a soft mass or a hard mass. Once we see it is a hard mass or it is a mixed kind of a elastography is coming, so you can actually target the area of the maximum hardness so that you give the pathologist the most representative tissue. So, and now coming to the breast MRI, as we all know, it is the most sensitive tool, though it is not very specific. And now initially, you know, a lot of patients used to be claustrophobic and they will not lie down in the MRI machine for 1 hour. Now we have something called fast MRI, abbreviated MRI, which we can use for, you know, high risk patients. Okay. And we can finish it in like, you know, 20 minutes. So we have everything is advancing and for the good, for the betterment. So early mammogram, as I told you, if you have a family history of carcinoma breast or endometrium and ovary, start the mammogram at the age of 30 to find the cancers early. And now interventions are also very important when we work with the surgeons. So especially preoperative localization, because we are finding, okay, we are searching smallest lesions, okay, which are non-palpable lesions. So for that, it becomes very important for the surgeon to reach the lesion when especially they want to do a very targeted surgery. So this is a patient, you can see the quite a large breast, but the lesion is very posterior. Okay, you can see it's almost in the retromemory area. Ultrasound done, it shows little lobulated mass, and biopsy was done. It was a benign phylloids. Patient has a family history positive, and we did a wire. You can see the wire hook is going through the lesion, and you know this is how we send the patient to. I mean, every surgeon has a different demand, so you can talk to your surgeon and you can give them the position of the wire and the your marks according to them, how they like it. We do it like this. That's how our surgeons want it. And then we send this x-ray after the wire to the theater or now WhatsApp is there. Just click a picture and send it to the surgeon and tell them that you are in position. So they do the surgery and they take out the mass and they send it to us for again specimen radiograph, because wire localization is incomplete without taking a specimen radiograph, because it will tell us three things. One is the mass is out, the wire is out, and the margins are clear. So this is very important. You have to work the cases in a proper way, as I said, for the benefit of everybody, for the benefit of medical fraternity as well as for the patient. So when you see masses like this which are irregular, ill-defined, definitely you have to do a biopsy, and we have availability of all the types of biopsy needles. Now we have a vacuum assisted biopsy, which is also becoming very popular. And this works on the principle of a basically vacuum. A vacuum is created with the help of a vacuum machine. A vacuum is created within the needle, and then the tissue falls into the trough. The cutter comes and it cuts, like you can see, the cutter comes and cuts the tissue and takes it back. That is the advantage of this, is it's only one insertion, single insertion, and you get multiple lesion. This is one of the cases where we have done the VAB. Tell me if you feel anything or pain, okay? And patient is done under local anesthesia. You can see a needle. Here is a fibroadenoma, and you can see it is just coming out. It just cuts the lesion and brings it very quickly. So this is how entirely fibroadenoma will get cut and come out. So this is a very, 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 very good thing. Okay, just done under local anesthesia without any complications. So these are few of the things, and then we get the collection. We collect the sample at the back of the probe, and this is how the samples look. And at the end of the procedure, this is what it is. Okay, so it's just super phenomena. So the full pathway of screening to the treatment is: you first screen the patient. If you detect a lesion, characterize it. If you suspect a cancer, confirm it by doing a biopsy, and then eventually which kind of a treatment patient has to undergo depending upon your immunohistochemistry and the type of a cancer. So early diagnosis is everything. So I request everybody and anybody listening to this speech today, please tell your women in the house to do an X-ray mammogram at the age of 40 if they have not done it, because seriously, the cancer has risen to any extent, and we have the capabilities to find it as early as possible. And only early diagnosis is everything, since there is no magic formula to avoid cancer. If it is there, if you find it early, you will be benefited. So we are here, we don't want to find cancers like this or this. We are here to find the cancers as small as this pepper size or even smaller than this, and make the families happy. Thank you so much.
Sir, Prabhakar sir, can you please unmute, sir? You are muted. Prabhakar sir, are you there, sir?
Sir, good evening.
Sir, Prabhakar
Sir,
sir?
good evening. Sir, can you hear me, sir? Sir, can you hear me,
Yes,
sir?
sir. Yes, sir. Yes, sir. Sir, I'm calling Prabhakar sir, the moderator. Sir is under mute.
Hello,
Yes, sir.
Ibrahim.
Unmute.
Ibrahim?
Sir. Yes, sir. Now you are audible, sir. Please, sir. Go ahead, sir.
Yes. Thank you for your excellent and informative talk on imaging options in breast carcinoma diagnosis, madam. Any question from the... Madam, you have talked about this tomosynthesis, contrast enhanced mammography, wire placement, contrast enhanced ultrasonogram, elastography, specimen radiograph, vacuum assisted biopsy. Very nice, madam. Very nice talk, madam.
Thank
Madam,
you.
in the vacuum assisted...
Prabhakar sir, got a question, sir.
Yes, please.
Hello. How common
Yes, sir.
CA breast is
How common is, sir? What?
in male patient, men?
It's quite common, sir. I can't give you the percentage, but it is
No,
quite
percentage will outlook and outcome.
outcomes are, again, it depends upon if you detect it early, it is a good outcome, because as it is as similar to as female cancer, sir, depending upon the stage at what you detected. And I think surgeons might be able to answer better than me. What is the thing?
Another
Sir,
question
this is
regarding
Dr.
the
Ibrahim.
racial. Madam Bhavana?
Sir, this...
Yes, sir.
Last question. Any racial difference in CA breast manifestation, India and other countries? Do you observe any racial difference pattern?
Sir, now actually we have also reached the same proportion. Before, I think according to me, what is happening is the incidence has increased, we are telling, but I feel that it is because we are detecting also so many cancers because of the good equipment now what we have and patient awareness, sir. So that's what also, when it is a registry, we are having showing the incidence more increase.
Okay. Thank you, madam. Thank you, Bhavana.
Thank you, sir. Thank you, sir.
Doctor, thank you, madam. Dr. Sairam, sir, Secretary National IMAMS, has raised a hand. Sir, any comments, sir?
Yeah, blacks, including Indians, the hereditary profile, BRCA1, BRCA2, if we can take, in the Western world, it is 10%. If for blacks and Indians, it is about 20 to 25%. So there is a preponderance in blacks and Indians more.
Yes, sir.
And any role of spectroscopy, madam, MRI spectroscopy?
Sir, when we find a cancer, actually, see what happens is when we do an MRI, we basically first what we follow is the morphological features. But whenever we feel that it looks like a cancer, it looks like a Barrett's 4+ category, we put a spectroscopy. But it is not necessary 100% that spectroscopy will be positive, like 3.2 ppm is the spectroscopy, choline peak, which comes in spectroscopy for CA cancer. So it's not necessary that all the cancers will have that, but we usually do it for all the patients whenever we are suspecting a lesion more than Barrett's 4, sir.
Okay, thank you, madam.
Yes, sir.
Instead, it is better to do core needle biopsy.
Yeah, anyway, sir, core needle biopsy has to undergo once it is 4A, B, C, or D, sir. 4A, B, C, or 5, sir, we need to do a core needle biopsy.
But usually in the core needle biopsy, we make 6 parts or 6 slices, isn't it, madam? But in vacuum biopsy, how many slices?
Sir, so your voice is not clear, sir.
Now it's clear, madam?
Yes, sir. Yes, sir.
Hello?
Yes, sir. Yes,
madam,
sir.
Usually in the core needle biopsy, usually we will take 6 slices or 6 passes, isn't it, madam? But in vacuum assisted biopsy, how many slices we should take, madam?
Sir, vacuum assisted, usually when we are doing under stereotaxis, we take 6 cores, 6 to 12 cores. And when we are doing ultrasound guided, depending upon what is the size of the lesion, you can take it. The difference between the vacuum and the core biopsies, in core biopsy, you have to do the insertion again, whatever number of cores you are taking, you have to do it insertion 3 or 4 times, depending what your pathologist is comfortable with. Like here in our institute, we take only 4 cores, sir. In vacuum, it depends upon when you have, if you are taking out the entire lesion, then you have to take out the entire lesion. It's just that, if this is the lesion, you place your needle under it, it will keep sucking, sir. So until this lesion finishes, you keep doing it.
Thank you.
Thank you, sir.
Ibrahim, can we go for the next talk? Ibrahim? Hello?
Yes, sir. We can go ahead, sir.
Yes. Now I invite for the second talk on recent advances in the surgical management of breast carcinoma. I want to invite my close friend and my postgraduate student at Madras Medical College, Dr. Mohammed Ibrahim. He is an MS, DNB, MRCS Edinburgh, FEBS, FSSO, FMAS, FAIS, FIAGES, FCGP, FCML. He has got a lot of fellowship degrees. He is the senior consultant surgical oncologist at Shifa Hospital and ESI Hospital at Tirunelveli. He is the joint secretary, Indian Medical Association, AMS, Tamil Nadu State Branch. He has got a lot of gold medals in his UG period and PG period. He has published a lot of papers in national and international journals. He is my postgraduate student at Madras Medical College. When I was working as assistant professor at Madras Medical College, he was the best outgoing student at that time, and he was my favorite postgraduate student at Madras Medical College. I wish all success to Dr. Ibrahim for his future career. Now I want to invite him to talk about recent advances in surgical management of breast carcinoma. Over to you, Ibrahim, Dr. Ibrahim.
Thank you, sir, for your wonderful words. And before going, there was a question on male breast cancers. So I just wanted to answer that also. So in fact, male breast cancer, the incidence is around 0.5 percentage. So for every 200 female patients of breast cancer, we can have one male breast cancer. Regarding the prognosis wise, the male breast cancer is having a poor prognosis because of low glandular elements. So the tumor will be most of the time misdiagnosed or missed. So because of which there is a late onset in the diagnosis, and there is faster infiltration into the chest wall muscles, and metastasis is more common. So that's why the male breast cancer is having a poor prognosis. That is mainly not because of the biology, tumor biology, but because of the late diagnosis, sir.
So age limit,
now,
sir. Age limit. Age limit,
sir, your voice is not clear, sir.
Sorry, age limit.
Age limit, there is no age limit, sir. It can come in any age. Once the a boy or the man is hormonally active, it is mainly a hormonally dependent cancer. So it is comes any age after 20 years, even in the elderly also, sir.
Thank you, sir.
Sir, is my slides clear, sir? Prabhakar, sir, can I start, sir?
Yes, please.
Thank you, sir. Thank you for the wonderful introduction, sir. And it's a privilege for me to present the recent advances in the surgical management of breast cancer under your moderatorship. So this is my alma mater. I am from Madras Medical College, where I did my general surgery, and from RCC Trivandrum, where I did my surgical oncology. So today we are going to discuss about the recent developments or advances in the management of breast cancer surgically. So we all know surgery is the first treatment option in most of the cancers, and very well documented in breast cancer. So what are the learning objectives here is we'll be reviewing the recent advances in breast cancer management and also on axillary dissections, and apply the current guidelines and explore future directions. So when we look at the breast cancer surgery, it is always done like more. If you operate more, it is better. But breast cancer surgery has evolved from the philosophy of maximum tolerated treatment to minimum effective treatment. So the challenge today is not how much surgery or how big the surgery we are going to perform, but precisely how we can tailor the surgery to each patient based on the biology of the tumor and also age and other characteristics. So in this presentation, why we are concerned about breast cancer is, as Dr. Bhavna was mentioning, it has become the most commonest cancer in the women worldwide. And also it is common even in India now. And there is increasing incidence in breast cancer and also decrease in the age incidence of breast cancer. But in spite of this, there is improved survival with multidisciplinary care, with surgery, medical oncology, radiation oncology, and targeted therapies. So that's why it is more important. So coming to the evolution of breast cancer, Halsted was the first surgeon who operated on the breast to remove a tumor. So that was called as the Halsted's radical mastectomy. So from there, we have evolved into various conservative measures from modified radical mastectomy based on a Fisher's concept. Then we moved to breast conservation surgery, sentinel node biopsy, and precision surgeries. In Halsted's radical mastectomy, you can see there was removal of the entire breast tissue, along with that the pectoralis major, pectoralis minor muscle, and only the chest wall with the ribs and intercostal muscles was there. So in spite of that, the patient had recurrent breast cancers, distant metastasis. So the thing changed from day one. It is not a localized disease. From day one, it is a systemic disease. So we have to treat the breast cancer systematically. So here you can see in this patient, the patient has undergone a Halsted procedure, radical mastectomy on the left side and a modified radical mastectomy on the right side. And you can see the difference. So in the modified radical mastectomy, we preserve the pectoralis major and pectoralis minor muscles. So the current international guidelines on surgical management of breast cancer is based on the NCCN, ASCO, ESMO, SSO guidelines, and all point towards breast conservation of the patient whenever it is feasible. So this is a type of precision surgery where personalized surgery is done based on the tumor biology. For example, in case of a triple negative cancer, we go for a modified radical mastectomy. But in case of a non-triple negative cancers, we go for a breast conservation surgery because we have other adjuvant treatments available. So all these advancement in general surgery or the surgical management of breast cancer is possible only because of the modern imaging and localization. So my previous speaker, Dr. Bhavna, was mentioning about the tomosynthesis and also the improvements in the MRI, contrast mammography, RFID, clipping of the tumors, intraoperative ultrasound. So because of these gadgets only, we are now able to do lot of improved and conservative procedures in breast cancer, thanks to the development in the radiology. So our basic conservation surgery is called the breast conservation surgery. It is always preferred for early breast cancer. So what do you mean by early breast cancer? So early breast cancer is T1 and T2 primary lesion with the mobile axillary node or N0 axilla. So if there is no node or it's a mobile node, and if it's a T1, T2 lesion, we can go for a breast conservation surgery. So even in case of locally advanced breast cancer, where it is T3, T4 lesions or N1 and N2 lesion, axilla, we can still go ahead with the breast conservation surgery, provided we do a neoadjuvant chemotherapy prior to the surgery and downstage the disease. So the main idea of the surgery in breast conservation surgery is focuses on tumor clearance and cosmesis. So how much margin has to be given? So previously, we all think that even if the tumor is very small, we have to remove the entire breast, but it is not so now. So the main concept is we need to maintain a margin. So in this picture, you can see what is a negative margin and what is a positive margin. So the recent guideline is there should not be no ink. There should not be any ink on the tumor. So in the picture, you can see some slices being done. You can see before cutting or before slicing the gross tumor, which is called the grossing of the tumor, the surface of the tumor mass, surface of the specimen is inked with a dark ink, and then we slice it. So you can see there is a tumor inside. So there is a complete negative margin here. So if there is no ink on the tumor margin, that means the margin is adequate. So this is the recent guidelines. So coming to oncoplastic surgery, what is oncoplastic surgery? Whenever we do a breast conservation surgery or a modified radical mastectomy, or a skin sparing mastectomy, we combine plastic surgical procedures to maintain the volume, texture of the breast and to maintain the symmetry. So when we combine the plastic surgical procedures along with the oncological procedures in the treatment of breast cancer, it's called as the oncoplastic procedures. So various techniques are there depending upon the location of the tumor, biology of the tumor, age and habitus of the patient, what is the shape and pendulous nature of the opposite contralateral breast, and also how often the patient is convenient with the procedure. So these are the different types of flaps, different types of oncoplastic procedures based on the location of the tumor. So there is something called therapeutic mammoplasty. Previously, mammoplasty was considered as a cosmetic procedure where it is called reduction mammoplasty or augmentation mammoplasty. But when we combine the surgical resection of the tumor, it is called as therapeutic mammoplasty. In certain conditions, like when there is a pendulous breast or a massive breast on the opposite side, we can even combine a reduction mammoplasty on the contralateral side to maintain the symmetry of the tumor. Symmetry of both the breasts. So there is something called prophylactic mastectomy. So what is prophylactic mastectomy? It is aiming to reduce the breast cancer risk by if it is more than 90%. So the indications are genetic predisposition, if it is a BRCA1, BRCA2, TP53, PTEN or ATM. Most common is the BRCA1 and 2. And if there is a high family history, high risk of family history, or when there is a previous chest radiation, which is very rare nowadays. And these are the indications for a prophylactic mastectomy. We all know about Angelina, who did a bilateral prophylactic mastectomy and also a bilateral oophorectomy for her BRCA1 mutation and increased risk. There is something called skin and nipple sparing mastectomy. We all know that the tumor margin has to be given only 1 to 2 centimeters macroscopically. So we can definitely conserve the skin, and even sometimes we can even conserve the nipple in certain instances. So when this is combined with other flap reconstructions or free flap or a pedicle flap, we can do a skin or nipple sparing mastectomy. The advantage is we can maintain the sensitive nature of the breast skin. So these are all some of the techniques of skin sparing mastectomy, where the native breast skin is preserved and the volume replacement alone is done with the autologous tissue with the fat and the muscle. So what is immediate breast reconstruction? So previously, breast reconstruction was done in a stage procedure. So surgical oncologist or a general surgeon does the breast resection procedure. Usually it's a modified radical mastectomy. And after completion of adjuvant chemotherapy, adjuvant radiation therapy, and if the patient wants, then we will consider a reconstruction. So this is called delayed reconstruction. So the delayed reconstruction may be based on autologous flap or an implant-based reconstruction. But most of the time, breast cancer patient, even though she knows there is a lump in the breast, hesitates to meet a surgeon or a doctor just because she need to undergo a mastectomy. This causes delay in the diagnosis, fear psychosis among the patient. So because of that, there is a delay in diagnosis, which ultimately translates into poor prognosis. So the main advantage is the psychological advantage of immediate breast reconstruction. So this immediate breast reconstruction is possible mainly because of the improvements in the oncoplastic procedures and also understanding the tumor biology in such a way that breast conservation surgery is sufficient and it is almost equal to a modified radical mastectomy. So this has to be kept in mind. So the clinical algorithm is after diagnosis of breast cancer, we always have to go for a MDT discussion, that is multidisciplinary team discussion, where a medical oncologist, surgical oncologist, radiation oncologist has to sit and discuss. And if there is an indication for neoadjuvant chemotherapy, we have to definitely give. For example, locally advanced operable lesion like a T3 lesion with N1 node, patient can either undergo a modified radical mastectomy or she can undergo neoadjuvant chemotherapy, downstage the tumor, and then later can undergo breast conservation surgery. Just because a tumor is operable, we need not go and keep the knife at the first instance. We can definitely downstage the tumor, treat the patient systemically, and then we can consider a breast conservation surgery at a later time. So even if there is a chance or need for a mastectomy, we can consider an immediate plastic reconstruction when the surgical field is amenable. So these are all some of the pictures of the oncoplastic procedure. You can see in the first picture, there is a tumor which has been undergone a wide excision with a positive margin. So we have done a re-wide excision with the oncoplastic procedure. So here, the most commonest muscle, autologous muscle used is the latissimus dorsi. The significance of latissimus dorsi muscle is it is one of the largest and flattest muscle which is just behind the breast in the chest wall, and it has multiple pedicles. The most important pedicle is the latissimus dorsi pedicle, and which arises from the axillary artery. And also it can be detached with very less donor morbidity and good cosmesis. And moreover, the skin texture and skin color matches with the breast skin tissues. So this can be brought anteriorly, and based on the skin paddle, we can maintain the contour as well as the skin texture after the reconstruction. So this is a marking of a latissimus dorsi flap, and you can see how well the latissimus dorsi flap is inserted into the breast tissue after a breast conservation surgery. So this is another latissimus dorsi flap. It is almost a partial mastectomy, which has been given a good contour and good cosmesis. And here, the latissimus dorsi flap not only can be used for a breast conservation surgery, but also can be used in a advanced or locally advanced breast cancer where skin closure is difficult. Here you can see in this patient a very big tumor almost involving the entire breast with ulceration and fungation. So here we have done a modified radical mastectomy with removal of the entire skin, and for skin closure, we have used a latissimus dorsi flap from the back, and we have used that insert for closure of the wound. So another good workhorse is the tram flap. So tram flap is also a pedicled flap. So tram is nothing but transverse rectus abdominis flap. So here, in most of the women who have a pendulous abdomen, we can use this. So usually the contralateral transverse rectus abdominis flap is used for the left breast. In this picture, you can see for the left breast, the right rectus abdominis muscle is used. Because of very good vascularity, this gives a very good result. And another advantage is we can even do a bilateral resection. A bilateral tram can be used at the same time. And also the cosmesis in the donor site it goes into the bikini line. So it is called the bikini incision, and also there is very less donor site morbidity. And another important thing is the sentinel lymph node biopsy. So whenever you see a breast cancer patient previously, the patient most of the time, at least 50% of the time, they will have a lymphedema. So the lymphedema is happening because of inadvertent removal of the axillary lymph nodes beyond the level of the axillary vein. So when it is removed beyond the axillary vein, the lymphatic drainage from the upper arm, forearm, and hand is also hampered, and because of which the patient may develop a venous or a lymphatic edema, which can even predispose to angiosarcoma of the limb. So this can be controlled with the technique called the sentinel lymph node biopsy, where the dye is injected, a methylene blue dye injected along the tumor peritumorally, and we identify which node. The sentinel lymph node is the first node from where the tumor, the lymphatic drainage is there. So we identify the first lymph nodes. So it may be 1, 2, or even up to 5. So those lymph nodes alone are removed. And then we send that sentinel lymph nodes for frozen section. And if it comes out as negative, we need not proceed with the axillary lymph node dissection. If the sentinel lymph nodes comes as positive, then we may proceed with the level 2 or level 3 axillary dissection, comprehensive dissection. So this is the concept of sentinel lymph node biopsy. And there is something called T flap. That is a thoracoepigastric flap. So in this, it is mainly used for the lower quadrant lesions. So lower quadrant lesions are very difficult to reconstruct because it is close to the chest wall and it is close to the inframammary crease. In this picture, you can see there is a tumor in the left breast with the scar of the core cut biopsy, and it is close to the inframammary crease, and it is in the lower inner quadrant. So for this, we are using a thoracoepigastric flap, which can be based medially or laterally. And in this case, we have used a laterally based flap. So you can see the resection area is marked. And once the resection is done, we raise a thoracoepigastric flap, which is marked there. And this flap is used to reconstruct the breast along the inferior. This gives very good contour. And also the scar tissue hides behind or disappears along the inframammary crease. So this video, you can see how the flap is being raised. You can see this, the flap harvesting has been done. And you can see when I raise the flap, you can see the chest wall. Here you can see the chest wall with clips marked. The clips are marked because to know where the tumor was there initially for giving the boost radiation. So this is the pectoralis major muscle and the rectus abdominis muscle. All these are seen. And the flap has the vessels which is placed from the outer side or laterally. So from there we raise the flap and we insert it here. So to give the proper insert. So this is the final picture after the flap insert. You can see good cosmesis and also the good volume for the inferiorly placed flap. And this has good outlook even in after the radiotherapy. So this is another case where we have done a latissimus dorsi. So the patient is put in a lateral position with the skin, the hand abduction. So this is the back of the patient. So you can see the latissimus dorsi flap muscle fibers in the flap. So this is a immediate reconstruction. We have tunneled the skin and we are going to bring the flap anteriorly to the breast area. So this patient is a locally advanced tumor. Patient has already undergone a neoadjuvant chemotherapy with the downstaging. So this is the anterior part. So you can see the exact texture and color which matches with the native breast skin. So both the wide excision and axillary dissection has been done through the same incision site, and we are able to bring the flap anteriorly. So this is the picture after the flap insert. So you can see so you can see the opposite breast symmetry. So even in case of a locally advanced tumor with proper multidisciplinary approach and proper neoadjuvant chemotherapy, we can downstage the disease and do a reconstructive procedure. So the present status of breast cancer surgery is every advance in breast cancer surgery has had one common goal, that is to improve the survival while at the same time preserving function, appearance, and quality of life. Our responsibility is to translate this evidence into compassionate and individual care. And the take home messages of this today's presentation is breast cancer surgery is becoming increasingly personalized. It is not the same treatment for all patients. It is one treatment for one patient based on various factors, including the biology of the tumor, personal preference, location of the tumor, age of the patient, everything. And there is de-escalation of axillary surgery from comprehensive axillary dissection to sentinel lymph node biopsy and surgery. And oncoplastic techniques has to be used in every case as much as possible without compromising the oncological safety. And neoadjuvant treatment has to be implemented in wherever possible so that we can downstage the disease and bring the patient to a breast conserving group. And multidisciplinary teamwork is mandatory, and expand breast conservation whenever it is safe, and use oncoplastic techniques to improve the quality of life, and follow evidence-based margin guidelines, which is no ink on the tumor margin. And less surgery can still achieve equivalent outcomes, and oncoplastic surgery expands the scope of BCS. Accelerated de-escalation has to be done evidence-based, and quality of life is highly important. So with this, we come to the end of the session. It's a very short discussion on a very large topic, and I am ready to answer the questions. Thank you.
Thank you very much, Dr. Ibrahim, for your excellent and very informative talk. Thank you. Ibrahim?
Thank you, sir. Thank you, sir. Thank you so much.
You were talked about that skin nipple sparing mastectomy. The lesion is just underneath the nipple. Is it possible to do skin nipple sparing mastectomy, Ibrahim?
Sir, the type of conservative procedure depends upon the location of the tumor. So whenever the tumor is in the central quadrant, nipple sparing is not advisable. So we can consider a skin sparing mastectomy where we need to remove the nipple areola complex along with the tumor and the breast tissue. So it always depends upon the location of the tumor and also on the tumor biology, sir.
You have talked about something about following the BCS way to give radiotherapy. The radiotherapy should be given to that wide local excision site only or to the whole breast. And how
Sir,
many?
it is always, yes, sir. It is always to the entire breast. The entire breast, whole breast RT has to be given. And extra boost has to be given to the tumor base. So that's why we mark the tumor base area. So our radiation oncologist, Dr. Prabhuraj, will be talking about that. So I think the usual dose is 50.4 grays to the entire breast, out of which I think some 5 to 7 fractions are given to the base alone, sir. It comes to around 10 grays to the base. So for that alone, we mark the area with a clips, surgical clips, so that it will be easily visible for during the radiation treatments.
What is a reverse mapping, Ibrahim, to avoid that lymphedema in the upper limbs when we are doing axillary dissection? Any idea about that?
Yes, sir. So the lymphedema, most of the time, it is mainly because of the venous and lymphatic component. So in the reverse mapping, we map the lymphatics of the non-breast areas like the hand, forearm, and all. So when we mark those areas, those lymphatics which drain our arm, upper arm, and forearm is getting marked, and we need to avoid those areas during the dissection. So it is like a negative image of a positive, so that we can avoid those areas and consider only a axillary dissection involving only the lymphatics which drain the breast tissue alone, sir. This also helps in preventing lymphedema.
Very good, super, good. Any questions from the attendees?
Ibrahim?
Yes, sir.
Do you advise FNAC for all suspected CA breast or straight away biopsy?
Yes, sir. So for any case of lump breast, the assessment is a triple assessment, sir. So first is the clinical assessment, followed by radiological assessment, as Dr. Bhavana was mentioning, and third is the histological evidence. So for histological evidence, it is always a core cut biopsy, which we do with a true cut needle. So the placement of true cut needle is very important. So in some places, we may consider FNAC if the lesion is not amenable or not palpable, or it is very small for biopsy. In those areas alone, we can consider FNAC. The main disadvantage with FNAC and advantage with true cut biopsy is FNAC cannot distinguish whether the lesion is a ductal carcinoma in situ or a invasive ductal carcinoma. So the main golden rule is to do a tissue biopsy rather than an FNAC whenever it is possible.
Well done, sir.
Thank you, sir. Thank you, sir.
Ibrahim,
Yes.
what is this VAP and stereotactic biopsy? What is the difference between these two?
Sir, I think ma'am was explaining about the vacuum assisted biopsy. So in that, the number of passes is less, and also the amount of tissue is more easily obtained. So this is mainly the difference in the technique of the lesion, sir. Technique which we assess the lesion and access the tissues. I think Dr. Sairam sir has raised hands. Sairam sir.
So in BRCA1 positive or BRCA2 positive or hereditary profile positive women, can you do breast conservation?
Sir, in BRCA1 and BRCA2, we in fact do a prophylactic mastectomy even on the opposite side, sir. So in those cases, they are in fact ideal cases for a bilateral tram reconstruction, where we can do a skin sparing mastectomy with removal of the entire breast tissue, and then do a reconstruction with a bilateral tram flap. So breast tissue has to be removed as much as possible.
So in operable breast cancer, like say for example triple negative breast cancer or quadri negative breast cancer or HER2 positive breast cancer, do you suggest neoadjuvant treatment or direct surgery, sir?
In triple negative, the guidelines is to go for a neoadjuvant chemotherapy followed by surgery, irrespective of the size of the lesion. In fact, we have to complete the neoadjuvant chemotherapy completely before going for surgery. And in HER2 positive, even in early breast cancer, it is better to go with a neoadjuvant targeted therapy, because it helps to immunologically sensitize the body to prevent further relapses. In fact, it develops the memory cells so that it can tackle future recurrences, even distant recurrences. I think Dr. Syed Ismail, medical oncologist sir, will be talking about these things. So the guidelines have changed even in case of an early breast cancer. With HER2 positivity, it is better to go with a neoadjuvant targeted therapy followed by breast conservation surgery later.
In postmenopausal women, BRCA1, BRCA2 positive hereditary, you do hysterectomy and bilateral salpingohysterectomy also along with breast cancer bilateral removal?
Yes, sir. So for BRCA1, BRCA2 mutation, we have to do a bilateral prophylactic mastectomy, the bilateral oophorectomy. Hysterectomy is not mandatory, but the patients usually want to do a hysterectomy because to prevent future recurrences. But BRCA1-2 mutation doesn't increase the uterine malignancies, but it's a routine to do a both breast as well as the ovary and the uterus.
Thank you.
Usually
Thank
we don't do in a single sitting, we do in a double sitting most of the time.
Thank you, sir. Excellent. Excellent, sir.
Thank you, sir. Thank you for the compliments.
Good evening, sir. In a post-menopausal woman, if the report shows a BRCA1 with bilateral reactive axillary lymph nodes, what should be advised to them, sir?
Sir, actually, BRADS means there is something called BRADS of the breast tissue as well as BRADS of the palpable lump, sir. So in this case, I think what you're telling is a BRADS of the breast tissue. So when it is BRADS of the breast 1, it is a normal breast tissue. So there is no lump there. And if the patient is having axillary nodes on both sides, we need to look for other causes of axillary lymph node enlargement. It can be even a non-malignant cause, even a tuberculosis or a sarcoidosis or other chronic granulomatous diseases. So that has to be ruled out. So if it comes out as malignancy, like with an FNAC or an axillary node biopsy, we can go with the whole body PET scan to assess a primary from other areas, because axilla is one area where it drains lot of thing, including a GIT also. Even we can have Irish nodes which are left axillary node in case of a carcinoma stomach. So multiple areas being drained in axilla. So we need to assess systemically, sir, totally.
Ibrahim, you told about something about that LD flap and tram flap. Recently, which myocutaneous flap is used for breast reconstruction? They are talking something about that deep inferior epigastric flap like that. Is there anything like that?
Yes, sir. So DIEP flap, so deep inferior epigastric flap is, so we have inferior epigastric artery and superior epigastric artery, two arteries which supply the rectus abdominis muscle. So the deep inferior epigastric flap can be used as a separate free flap where it can be anastomosed with the lateral thoracic artery, sir. So DIEP flap is a, all the tram flap is a pedicle flap, but DIEP flap is a free flap, sir.
Right. Okay. Fantastic. Fantastic presentation. Thank you very much.
Thank you,
more
sir.
questions,
Thank you, sir.
then we can do the third talk. Can I invite the third speaker, Ibrahim?
Yes, sir. Dr. Syed Ismail, sir, is there.
Yes. Now I invited Dr. Syed Ismail Nawab. He is now working at the MGM Cancer Institute. He's a medical oncologist. Now I invite him to talk about the medical management of the breast carcinoma in the era of targeted therapies. He will, Dr. Ibrahim will introduce Dr. Syed.
Okay. One minute.
Dr. Ismail, sir?
Yeah, I am here. I'm sharing my slides.
Yes, yes sir. Yes, sir. Please.
Yes, sir. It is getting shared, sir. You can do
Yeah,
slide show, sir.
Okay, sure. Good evening to one and all. I am Dr. Syed Ismail Nawab John, as a clinical lead and senior consultant in medical oncologist, MGM Cancer Institute, Chennai. First of all, I thank the organizer and Dr. Ibrahim who given me this chance regarding to talk in the medical management of breast cancer in the era of targeted therapy. Here we know previously 20 years, 30 years back, only cytotoxic chemotherapy is there for treating the breast cancer patient. Nowadays, the scenario has changed from cytotoxic chemotherapy to precision oncology. The aim of treatment in the breast cancer for stage 1 to stage 3, it is a curative attempt. For stage 4, it is a palliative attempt. The role of systemic therapy in curative attempt, it is given in the form of neoadjuvant therapy. And the rationale for giving this neoadjuvant therapy makes the unresectable tumor into a resectable one. By giving this cytotoxic chemotherapy, reducing the size, make it amenable for surgery. In adjuvant therapy, the rationale for giving this adjuvant therapy is to address the microscopic cells and thereby prevent the recurrence. For that, after surgery, giving systemic therapy is the adjuvant therapy. In stage 4, the systemic therapy plays a main role in the aim of palliative intent. In palliative intent, there is no cure, only to improve the quality of life of patient till the patient dies and thereby improve the survival. The learning objectives today's class is understanding the molecular classification in breast cancers, review biomarkers, that is molecular markers, discuss targeted therapies and the role of immunotherapy in breast cancer, and sequencing the treatment as first line, second line, third line, and future directions in breast cancer management. Coming to epidemiology, the most common cancer in women, and it is 2.3 million new cases is reported per year. Major cause of cancer mortality. Nowadays, survival is improving due to this precision medicine. This pictogram shows the most common cancers in females in India. The breast cancers reported as 30.4%, CS cervix is 10.2%, the oral cavity cancer is something around 5%, and lung cancer is 4.3%, and the other cancers are 38.9% reported in females in India. The mortality rate is also high with the breast cancer. It is around 23.2%. The CS cervix stands second, 8.8%, and ovary is 6.9%. And third one is the lung. Fourth one is the lip and oral cavity cancers. Other cancer stands for 43.3%. The major molecular classification in breast cancers are classified as luminal A, luminal B, HER2 positive, triple negative. The definition for luminal A is the hormonal receptor status ER positive, PR positive, HER2 negative, and low Ki 67, that is less than 12%. In luminal B, classified as hormonal receptors positive, HER2 new plus or minus with high Ki 67, that is more than 12%, and breast cancers with positivity of HER2 new. And finally, the triple negative breast cancers, options of all three markers like ER, PR, and HER2 new. The other molecular biomarkers for planning for any target therapy, we have to look for molecular biomarkers like ER, PR, HER2 new, Ki67, PDL1, BRCA1 and 2, PIK3CA, and AKT, P10, ESR1 mutation, NTRK fusion, MSI, that is macrosatellite instability high, tumor mutation burden, and HER2 low and HER2 new ultra low. Evaluation of treatment. Here, previously only systemic therapy is there for treating the cancer patient, followed by hormonal therapy, followed by HER2 targeted therapy for those cancer patients presenting with HER2 new. And nowadays, PARP inhibitors are there for BRCA1, BRCA2 positivity breast cancers. And later the advancement is CD4 bar 6 inhibitors, that is cyclin dependent kinase 4 and 6 inhibitors, PIK3CA inhibitors, AKT inhibitors. Nowadays, antibody drug conjugates are used for treating the cancer patient and immunotherapy. For breast cancers with hormonal receptor positive and HER2 negative disease, the first line treatment of choice is aromatase inhibitors with cyclin-dependent kinase 4 and 6 inhibitors, or fulvestrant, that is anti-estrogen, with CDK4 and 6 inhibitors. The second line of treatment in hormonal receptor positive HER2 negative diseases switch to endocrine therapy like tamoxifen, exemestane, like this drug, and address the target mutation. Suppose any molecular biomarkers are present in the cancer patient, we can address with target therapy. For hormonal receptor positive and HER2 negative early stage, this treatment is given as adjuvant setting, that is after surgery. If high risk of recurrence, suppose the patient presenting with lymph node positivity more than 4, the treatment of choice is endocrine therapy, that is either aromatase inhibitors with cyclin-dependent kinase 4 and 6 inhibitors, that is abemaciclib for 2 years or ribociclib for 3 years. If germline mutation is positive, that is BRCA1, BRCA2 mutation is present in the patient, administered the PARP inhibitors, that is olaparib, for 1 year following the adjuvant chemotherapy. For advanced hormonal receptor positive and HER2 negative breast cancer, the first line of treatment is endocrine therapy, that is aromatase inhibitors or anti-estrogens like fulvestrant, along with cyclin-dependent kinase 4 and 6 inhibitors like ribociclib, palbociclib, abemaciclib. The second line, that is after the failure to first line, we plan for second line, and behind triggered by progression, select based on the NGS study mutations. If PIK3CA mutation is positive after this NGS study, it is a predictive marker. The drug of choice is PIK3 inhibitors like alpelisib and inavolisib along with the fulvestrant. That is, it is given in the form of injection as anti-estrogen drug. And if AKT or P10 or PIK3CA alteration present means AKT inhibitors like cabivasertib and fulvestrant is used. If ESR1 mutation, that is estrogen receptor mutation present means oral SRD is used. SERD stands for selective estrogen receptor degradation. The drug name is elacestrant is the treatment of choice. If no actionable mutation are present, mTOR inhibitors like everolimus and exemestane is the treatment of choice. Suppose the patient having endocrine refractory or late line, if HER2 low, that is the score is immunohistochemistry with ISC1 or ISC2 plus and FISH negative, the antibiotic drug conjugates are used, that is Enhertu, trastuzumab deruxtecan is the treatment of choice. If HER2 new is 0, the other drug antibody drug conjugate like sacituzumab govitecan is also used for this hormone positive HER2 negative breast cancer. Cyclin-dependent kinase 4 and 6 inhibitors drugs are palbociclib and ribociclib, abemaciclib. The benefit of these drugs are it improves the progression-free survival and increase the overall survival benefit, delay chemotherapy, and preserves the quality of life patient. For those patients giving only chemotherapy, the quality of life is down due to toxicity of the chemotherapeutic drugs. The PIK3 inhibitor pathways, this PIK3CA mutations activates the PIK3A, and this leads to activation of AKT, and AKT leads to mTOR activation, thereby cell proliferation leads to progression of the cancer cells. The targeted therapies for PIK3 is alpelisib, cabivasertib, and everolimus is the treatment of choice for these pathways. Coming to PARP inhibitors, the eligibility for PARP inhibitors are germline BRCA mutation, HER2 neo negativity. The drugs used are olaparib and talazoparib. ESR mutation occurs after aromatase inhibitors resistance. This mutation can be detected by doing the testing like circulating tumor DNA. The treatment for ESR mutation positive breast cancers are elacestrant and improves the progression-free survival and overall survival of the patient, those who are having ESR1 mutation. Coming to HER2 positivity disease. The HER2 positive disease, the drug of choice are trastuzumab, pertuzumab, and TDM11. The other drugs is trastuzumab deruxtecan. This is the antibody drug conjugates. The other drugs like tyrosine kinase inhibitors like tucatinib, pyrotinib, and mergatuzumab. These are the drug of choice for HER2 positive disease cancer patients. In the HER2 positive early stage setting, the neoadjuvant, that is pre-surgery, already I told this pre-surgery is given to make unresectable tumor into resectable one. Here the systemic chemotherapy is given along with the dual HER2 blockade using trastuzumab and pertuzumab given simultaneously. And in adjuvant assessment, the post-surgery evaluation, the pathological complete response, complete another 1 year of trastuzumab plus or minus pertuzumab as a maintenance therapy. Suppose the histopathological examination shows residual disease present after the neoadjuvant chemotherapy, switch to antibody drug conjugates like trastuzumab ematansine, that is TDM1. If extended adjuvant options are hormone receptor HER2 positive with high recurrence, add neratinib, oral tyrosine kinase inhibitors for the 1 year post trastuzumab as a maintenance therapy. Coming to advanced setting and metastatic setting in the HER2 positive breast cancer, the first line drugs used is taxane chemotherapy along with the anti-dual HER2 blockade like trastuzumab and pertuzumab. Suppose if it is failure to first line, the second line drug of choice is antibody drug conjugates, that is trastuzumab deruxtecan. It is preferred over TDM1 for superior progression-free survival overall survival in the overall survival. The third line and behind sequence based on the clinical presentation. If active brain metastasis present, then the treatment of choice is tucatinib, trastuzumab, and capecitabine. That is a high CNS penetrance is seen with this combination. The alternative monoclonal antibody is mirvetuximab, and along with chemotherapy is the other alternative antibody drug conjugates trastuzumab ematansine is also used. The first line HER2 positive, the landmark trial is the Cleopatra trial. In this Cleopatra trial, the drugs commonly used are taxane, trastuzumab, and pertuzumab, which improves the progression of free survival and overall survival of the patient in the HER2 positive breast cancer. Coming to second line for HER2 positive breast cancer, according to Destiny Breast 03 trial, trastuzumab deruxtecan is used. It is superior to TDM1 and it has the highest progression-free survival. Third line chemotherapeutic drug for HER2 positive breast cancer, according to HER2 claim, here tucatinib, trastuzumab, capacitinib combination is used. It is excellent for the patient, those who have CNS metastasis in HER2 positive breast cancer. HER2 low disease. The definition for HER2 low disease with ISC marker, HER2 shows 1 positive or ISC 2+ with FISH negativity is called as HER2 low disease. The drug of choice for the HER2 low disease, trastuzumab deruxtecan. According to this landmark trial, Destiny Breast 01, it shows the improved overall survival benefit in this patient. Coming to triple negative breast cancer, here main important things we have to test the PDL1 in PDL testing and BRCA testing, HER2 low assessment, and TROP2 testing. This TROP2 stands for the tropoplastic cell surface antigens. There is a immunotherapy role in triple negative breast cancer. The main immunotherapeutic drug used in the triple negative breast cancer is pembrolizumab. The other immunotherapeutic is toripalimab is also used in the triple negative breast cancers. According to this landmark trial, Keynote 335, it shows PDL1 with CPS score is more than 10. The treatment of choice is chemotherapy plus pembrolizumab. It shows improved overall survival and progression-free survival in the patients. In triple negative early stage settings, the neoadjuvant checkpoint inhibitors like pembrolizumab immunotherapeutic drug combined with chemotherapy, the pre-surgery followed by a single agent pembrolizumab post-surgery as the maintenance therapy. Adjuvant alternative is, suppose after completion of surgery, the post-operative pathological examination shows any residual disease remains, so means and the patient carries a germline BRCA1 BRCA2 mutation at the PARP inhibitors. Suppose if there is no BRCA1 BRCA2 mutation, if there is any residual lesion, and capacitinib drug as a maintenance therapy along with pembrolizumab. In the advanced and metastatic setting of the triple negative breast cancer, the first line of treatment is if PDL1 positive, that is CPS score is more than 10, The drug of choice is pembrolizumab and chemotherapy. If germline BRCA1 BRCA2 mutation is positive, you have to add the PARP inhibitors like olaparib and talazoparib. And if PD-L1 is negative in that patient, that PARP inhibitor is the treatment of choice as in the advanced setting of the triple negative breast cancer. The second line and behind, the antibody drug conjugates like sacituzumab govitecan is used, targeting the TROPA2 target. Like the TROPA2 stands for the tropoplastic cell surface antigen, highly preferred regardless of the biomarker status. If head to low on subtype ADC, trastuzumab deruxtecan is also used in the triple negative breast cancer patient. Sacituzumab govitecan is the antibody drug conjugates. Its target is tropoplastic cell surface antigen present in the breast cancer tumor cells. According to this trial, ASCENT trial, it shows the improved progression-free survival and overall survival with improved quality of life of patient by using this sacituzumab. The other emerging antibody drug conjugates are tatupotamab deruxtecan and patritumab deruxtecan, larotuzumab vedotin, and disitamab vedotin ARX7AA. All these antibody drug conjugates are in the pipelines. The precision oncology stands for NGS to look for the molecular markers. It gives idea about the predictive markers to select the treatment, and it also gives the prognostic marker, and any resistance is present for the previous treatment. It also dictates in the NGS study. And the liquid biopsy, suppose the biopsy, two-cut biopsy is not possible for the recurrent lesion of the breast cancer. Liquid biopsy also done with a sample of blood. And this ctDNA stands for the circulating tumor DNA. It is used for detecting this minimal residual disease or presence of ESR mutation. Also, ctDNA testing, it gives the ideas for making the treatment personalization. Coming to algorithm of targeted therapies in breast cancers, first confirm the diagnosis and perform the biomarkers profiling like ERPR, head-to-neo, and NGS studies, and look for the germline mutations like BRCA1, BRCA2, and PIK3CA mutation, ESR1, PD-L1, hormone receptor positive and head-to-negative breast cancer, mainly classified into two types. One is the early stage and another one is the advanced or metastatic stage. In high risk patient, in early stage, hormone positive head to negative breast cancer with high risk feature, presence of node more than 4 nodes you consider as a high risk, or less than 4 nodes with grade 3 lesions, and size of the 1 to 3 with size of the lesion more than 5 centimeter. All these three criteria are considered as high risk. For all those high risk individuals, the treatment of choice is, we heard in the adjuvant setting, is endocrine therapy, that is cyclin dependent kinase 4 and 6 inhibitors. The drugs is abemaciclib, it is used for 2 years, or ribociclib for 3 years. Suppose if there is germline BRCA1 and 2 mutation is present, and the olaparib drug is added, that is a PARP inhibitor. For hormone positive head to negative advanced breast cancer, the first line treatment is the endocrine therapy, that is aromatase inhibitors or fulvestrant, along with the cyclin dependent kinase 4 and 6 inhibitors. And the drugs for cyclin CDK4/6 inhibitors, abemaciclib, ribociclib, palbociclib are used. In the second line setting, which has progressed after this endocrine therapy and cyclin dependent kinase 4 and 6 inhibitors, look for the NGS study, and in NGS study the PIK3CA mutation is possible, means, and PIK3 inhibitors plus fulvestrant is the treatment of choice. Suppose AKT and P10 is positive, then oral SERD, that is selective estrogen receptor degradation drugs are used, and ECR1 mutation is present on the oral SERD is the treatment of choice. In the late line, suppose head to low in the hormone positive head to negative patient, the treatment of choice is antibody drug conjugates like trastuzumab deruxtecan is the treatment of choice. Head to low for this patient, and the other antibody target conjugate drug is the sacituzumab govitecan is also used. Coming to head to positive breast cancer for early stage in neoadjuvant setting, chemotherapy like taxane or carboplatin along with the dual HER2 blockade. Trastuzumab, pertuzumab is the treatment of choice. After completion of 6 cycles of chemotherapy, patient underwent MRM or surgery. We have to look for the post-op biopsy report. If complete response is there, means pathological complete response is there, means continue the trastuzumab along with the pertuzumab. And suppose if there is a patient is not affordable for pertuzumab, means without pertuzumab we can de-escalate this drug continuing with only trastuzumab. Suppose if the patient after surgery, the post histopathological report shows us presence of residual disease, the antibody drug conjugates like trastuzumab emtansine, that is TDM1 is the treatment of choice. For advanced metastatic first-line therapy in the HER2 positive breast cancer is taxane plus trastuzumab and pertuzumab. Who failed with this first line means the second line treatment of choice is ADC, that is trastuzumab deruxtecan is used. In third line behind we use this margetuximab with tucatinib and trastuzumab and capecitabine is used for the patient with CNS metastasis. Coming to triple negative breast cancer, for early stage, neoadjuvant and adjuvant, the pembrolizumab is used for the triple. Immunotherapy is there is role in the triple negative breast cancer. In pembrolizumab and chemotherapy is used. Once 6 cycles is completed, patient underwent surgery, means we have to look for the if there is a complete response is there, means continue with pembrolizumab as for 1 year as a maintenance therapy. Look for any germline BRCA1 BRCA2 mutation. Suppose germline BRCA1 BRCA2 mutation positive, add the PARP inhibitors like olaparib. For advanced metastatic triple negative breast cancer, the first line treatment is for PD-L1 pembrolizumab along with chemotherapy. Presence of germline BRCA1 BRCA2 mutation, we have to incorporate PARP inhibitors in this condition. Second line, for failure to first line therapy, the second line therapy, the treatment of choice is antibody drug conjugates, that is sacituzumab govitecan. For HER2 low is also this sacituzumab govitecan is used. Coming to toxicities of these targeted therapies like cyclin dependent 4/6 inhibitor, the main complication is neutropenia and diarrhea. For HER2 therapies like trastuzumab, pertuzumab, TDM1 and trastuzumab deruxtecan, cardiotoxicity is the main issue. And for HER2, that is trastuzumab deruxtecan, that is antibody drug conjugates, interstitial lung disease is the main problem with this drug. And coming to PIK3 inhibitors, the main complication is the hyperglycemia. Patient will have this glucose level more than 500 or 600. In PARP inhibitors, the main complaints is fatigability and anemia. In immunotherapy like checkpoint inhibitors, the immune-related adverse events are things like colitis, pneumonitis, and patient will land up with hypothyroidism and endocrine abnormalities, skin rashes, and cytokine release syndrome is also more common with this immunotherapeutic drug. In future direction of treating these breast cancer patients, one is HER2 ultra low. HER2 ultra low, the definition is in ISC, this HER2 is 0 plus. And the mild staining of cytoplasm is considered as a ultra low. And vaccines are also coming out with neoantigen, and in future this CAR T cell therapy is also playing it is in the pipeline, and other like bispecific antibodies, radioligand therapies, and artificial intelligence guided precision oncology is also plays a main role in the breast cancer patient, and the MRD, that is minimal residual disease guided therapy, is also coming up. Take-home messages is biomarkers testing is essential in treating the breast cancer patients, and precision medicine has transformed outcomes. Cyclin-dependent kinase like 4 and 6 inhibitors are standard in hormone-positive HER2 negative disease. Trastuzumab deruxtecan has reshaped HER2 positive and HER2 low treatment. Immunotherapy benefits selected triple negative breast cancer patients. The targeted therapies like PARP inhibitors, anti-PIK3 inhibitors, AKT inhibitors, X1 personalized options Antibody drug conjugates plays a main role in the making as a treatment landscape in treating the breast cancer patients. These are some landmark trials for treating the cancer patients in medical oncology for hormone positive head to negative Mona Lisa, Monarch, and Paloma trial. PIC3CA Solar trial is there. ESR1 is Emerald, and BRCA is Olympia AD, and Embraca. And head to Cleopatra is the landmark trial, and Catherine trial, Affinity, Destiny Breast 03, and head to Klein. For head to low, Destiny Breast 04 place is the landmark trial. In triple negative, the landmark trials are Keynote 355, Keynote 522, and Ascent trials. Thank you.
Sir, thank you very much, sir, Dr. Syed Ismail Nawab John, sir, for your very detailed, excellent, and informative talk on medical management of carcinoma breast, sir.
Thank you, sir.
Any questions from the attendees? Sir, you had talked about the trastuzumab drug, sir. What is the dose and how many years it should be given, sir? And what are the common side effects of that trastuzumab?
Trastuzumab, sir.
Yes, sir.
Trastuzumab is the anti-HER2 blocker drug, sir. And this is the targeted therapy, and it is used in the form of per mg per kg, depending upon the weight of the patient we are treating. Suppose if we are planning for every 3 weeks once, means we have to give the loading dose 8 mg per kg, followed by 6 mg per kg, along with the chemotherapy drugs we have to give, sir.
How many years it should be given, sir?
1 year, sir.
What is the cost of a single vial, sir? Trastuzumab?
Trastuzumab for original, it is coming something 70,000 to 80,000, sir.
Okay.
Original molecule. Now generics are available, sir. Within 15,000 to 25,000 is available, sir. Generic drugs are also available.
What is the side effect of that olaparib, sir?
Olaparib main side effect is the anemia, sir, and fatigability is the main side effect, sir. Patient will present like a pure red cell aplasia.
Okay.
And neutropenia is also reported with this olaparib.
Any other question from the audience? Anybody wants to raise any questions? If there are no questions, then we can end this session, sir. Thank you very much, sir. Medical oncologist, sir, Dr. Syed Ismail Nawab John.
Thank you, sir. Thank you.
Sir, now I invite Ibrahim.
Now yes, sir. Dr. Prabhuraj is there, sir. Dr. Prabhuraj, he is a radiation oncologist.
Radiation oncologist at Kaveri Hospital and Purune Hospital at Tirunelveli. He is going to talk on radiotherapy techniques in breast carcinoma management. Radiotherapy techniques in breast carcinoma management. Over to you, Dr. M. Prabhuraj.
Good evening, sir. Good evening.
Yes.
Sir, Prabhuraj, sir, unmute, sir.
Sir, good evening, sir. First of all, I thank AMS Wing, IMAT NSB, especially Sandal sir and Brian sir for giving me this opportunity. Let me share the current. One second, sir. Video and make. Sir, hope my PPT is visible, sir.
Yes, sir. Visible, sir. Visible, sir.
Yeah. So my role is on radiotherapy. So as in a curative intent for breast cancer, it is either radiotherapy plays the role only after either chemotherapy, neoadjuvant chemotherapy followed by surgery, or surgery followed by chemotherapy. Then anyway, my the role of radiation is only after surgery and chemotherapy. So is this talk also. So my role is only after both of their talks, surgical oncologist and medical oncologist. So why radiotherapy here? So because the most common site of recurrence is local site. Since not all recurrences are salvageable, prevention of recurrence is more important. So this is the main reason for radiotherapy. Next to the one second, sorry, my slide is not moving. 1 second. So breast RT in last few decades have evolved much actually. Initially, it was only radiation. Then it was radiation along with chemotherapy. Then for adjuvant RT after BCS or MRM. Then even now it is for some occasions we are giving neoadjuvant settings also. Then the palliative setting for local regional disease with the LABC with skin extensive skin involvement and bone mets and brain mets. Role of RT in carcinoma breast, RT in early breast cancer, partial breast irradiation, RT in locally advanced breast cancer, LABC, RT in oligometastatic breast cancer, then palliative RT to metastatic disease. So coming to the role of radiation in early breast cancer. So usually early breast cancer includes stage 1 2A, that is a tumor size of T1 and T2 with N0 or N1 disease. Local therapy includes modified radical mastectomy, MRM, or breast conservation surgery, BCS. So coming to the BCS, removal of only the tumor with adequate margin with or without axillary lymph nodal dissection instead of mastectomy followed by radiation to the breast. So BCT is very simple as lumpectomy plus or minus RT. So this is the picture for the staging actually. So early stage, it is T1, T2, nodal disease N0 and N1. To some extent in T3, N0 also can be included as in an early stage. So this is a trial for adding radiotherapy to the after BCS NSABP trial. So we can see the local failure has BCS followed by RT improves the local control. So we can very well see in that picture CS plus RT is only 14 whereas it is local control is 39 with only with surgery. So why whole breast irradiation after BCS? When surgery is done alone, there are more failures at the margin. When radiotherapy is given alone, more failure at the epicenter. Surgery is to remove grossly visible tumor with adequate margin, whereas radiotherapy is to treat larger volume of the tissue that may harbor residual disease with moderate dose. So indications for BCTs, first the patient should be properly motivated. So cooperative patient should be there. The tumor size should be T1 or T2. Clinically, there should be no nodes or it should be N1 nodes. Then adequate tumor breast ratio should be there. So absolute contraindication of breast conservation surgery is inflammatory breast cancer, invasive breast cancer with extensive skin involvement, inability to clear multiple positive margins after one or more re-excision. Then the triple negative breast cancer, more than 2 lesions involving different quadrants by MRI. Any lesion that is equal to or more than 5 centimeter, then the BRCA mutation carrier, clinically N2 or N3 disease. These are all absolute contraindication for BCT. So relative contraindication of BCT is patients with known family history of breast cancer, pathological P53 mutation, active connective tissue disease involving skin, history of prior radiation therapy to affected area, poor cosmosis results, large medial lesions, unfavorable for with less breast ratio. So BCT in technical aspects, pre-op evaluation of tumor is must by the radiation oncologist. Sir has, while giving his presentation, Ibrahim sir has told about keeping the clips in the area of the tumor area. So minimum margin is around 1 centimeter all around. Separate incision preferred for primary and axillary region. Surgical clips are left in order to visualize the tumor. So the standard approach of BCT is breast conservation surgery, that is a wide local excision with axillary lymph nodal dissection or a whole breast irradiation. So usually we will give conventional dose, which is 45 to 50 gray with the 25 fractions settings of 25 fractions, or hypofraction doses, that is 40.5 gray, which is given in 15 fractions. Boost to tumor bed. He touched the point actually. So I think someone has asked this question also, how much boost we have to give the tumor. So boost to the tumor bed should be around 10 to 16 gray, sir. Regional RT is only when indicated and depends upon the post of HPE. So role of axillary RT undergoing sentinel lymph node biopsy. So for N0, no further treatment is required. For N1 disease with one node positive, high tangents of radiation are used. For two nodes, axillary nodal irradiation is must actually. For more than two nodes, axillary dissection, we have to proceed with axillary dissection. More than two nodes positive, we have to proceed with axillary dissection. So role of RT versus axillary lymph node dissection. So this study is for, AMARA study is for the omitting surgical intervention with giving radiation. So in this case, it's clinically T1 bar T2 N0 disease, VCS bar mastectomy, sentinel lymph node biopsy positive patient, axillary lymph node dissection with whole breast RT versus whole breast RT with regional nodal radiation to axilla and medial supraclavicular node is considered. So axillary lymph node dissection is not required. So I'm repeating, axillary lymph node dissection is not required in T1, T2 with the sentinel lymph node positive patient when RT is directed to axilla. So this is for less than 3 nodes positive. So as I said in my previous slide, more if 3 nodes mean definitely we have to proceed with surgical dissection. So if it is less than 2 nodes or less than 2 nodes, we can give only axillary radiotherapy, results in significant less morbidity. So we can avoid lymphedema to the lymphedema actually. So that is the main reason here RT is preferred than surgical intervention for axillary dissection for sentinel lymph node biopsy if less than 2 nodes are positive. So these are all the modern techniques of radiotherapy. Usually we will give conventional tangential field, then followed by nowadays advanced technique used photons are 3D CRT, IMRT, arc therapy, tomotherapy, and proton therapy. So usually what we do is we used to properly position the patient with the breastbone, palpate the tumor's mass, and we have to cover the proper copper wire around the ipsilateral breast, scar, and contralateral breast. Thermoplastic mold should be used for treatment. We have to take the CT scan and proceed with treatment planning system. We have we should plan according to the target delineation, planning to achieve the desired dose to the breast and treatment area and to the OAS. Quality assurance is much important here. Then we have to proceed with the treatment execution. So rationale for boost is even if surgical margins are negative, after BCS, approximately 30% of risk of microscopic tumor is seen along the tumor bed actually. So most recurrences around 65 to 80% are located in the vicinity of the tumor bed. So boosting the tumor bed aim to reduce the local recurrence and reduce the toxicity and improve the cosmosis due to reduced dose of OAR. So techniques of breast irradiation is usually photons with cobalt emission or LINAC emissions, then protons and permanent seed implants. When it comes to partial breast irradiation, we can use electrons, either electrons or interstitial brachytherapy or mammocyte or intraoperative radiotherapy. So delineation of lumpectomy cavity. So this is where surgeons play a major role. So this is highly subjective and geographical miss will be there if at all we miss the lumpectomy area. So surgical clips are more important. We can use ultrasound guided or CT guided or MRI guided evaluation. For surgical clips, it is a radio opaque clips and it can be kept in 4 corners and the center, feasible for surgical cooperation. It is highly inexpensive. Detection by fluoroscopy or CT can be very much possible. Disadvantages, migration of clips and change in position over 3 to 4 months. So CT-based boost delineation is accurate localization, planning in treatment position, excellent definition of breast tissue. The disadvantage is difficult to distinguish granular breast tissue and further in the anatomy. Surgical clips necessary for delineation varies with window setting actually. So another concept of irradiation is accelerated partial breast irradiation. This we usually give in a short duration. So usually we do partial breast irradiation by treating the lumpectomy bed plus a 1 to 2 centimeter margin rather than a whole breast. We need not treat the whole breast. We can treat only the lumpectomy site along the margin. Techniques will be usually by brachytherapy. Brachytherapy is maybe either interstitial brachytherapy or intracavitary, which is balloon catheter brachytherapy. In the picture, you can see the balloon catheter brachytherapy is the mammocyte actually. Then the external beam radiotherapy using regular 3D CRT and the electron therapy. The second picture over the right corner is upper right corner is intraoperative radiotherapy machine actually. So through which we can give intraoperative radiotherapy immediately after surgery also in the theater itself. So rationale for ABBA, 70 to 90% of recurrences occurs at the immediate vicinity of primary tumor. Incidence of elsewhere failure is almost 0.5 to 3.5%. Several studies on mastectomy specimens suggest residual disease may extend around the margins around the excision cavity. So these are all. This is the suitability for APBI, accelerated partial breast irradiation patient. So the suitability criteria is age should be more than 50 years, margins negative at least by 2 millimeter. T stages it should be either TAS or T1. So DCAS if all the below screen detector low to intermediate nuclear grade, size is less than 2.5 centimeter, resected margin with negative at more than 3 mm. Actually, if the suitability criteria is not applicable, means we cannot proceed with partial breast irradiation. We have to go with only the regular remnant breast radiation only. So if it is if this partial breast irradiation is only it is feasible only with this suitability criteria. The unsuitable criteria is age less than 40 years and margin positive and DCS more than 3 centimeter. So the classification of techniques I earlier mentioned, it is brachytherapy using intraluminal mammocyte or permanent breast seed implant or electronic breast brachytherapy, non-invasive image breast brachytherapy, then intraoperative brachytherapy, external beam using photons, electrons, and protons. So this is the various pictures showing. This is first picture is interstitial brachytherapy. The second one is mammocyte. The third one is intraoperative brachytherapy. The fifth one is regular 3D CRT technique or IMRT technique using a linear accelerometer. So what are the common side effects that include skin toxicity in 1/3? This is acute toxicity. Inframammary fold, treatment break will be there. Quality of life will be a bit disturbed. So in the late toxicity include cosmetic outcome, breast shrinkage, telangiectasia, breast fibrosis, and breast edema. So risk factors of local relapse are young age, positive margins, extensive intraductal component, LCAS, BRCA1 and 2, large tumors, nodal positive status, ERPR negative, and HER2 positive tumors. So the question when RT can be avoided post BCS. Usually when we do breast conservation surgery, this has been followed for a long time. RT cannot be avoided. Usually after breast conservation surgery, RT cannot be avoided. When we do mastectomy, RT can be avoided in case of if it is a T1, T2 disease with N0 node, N0 node, RT can be avoided. But usually in that stage also, after BCS, RT cannot be avoided. But now there are some criteria when RT can be avoided. So that is consider elderly, low risk, that is T1 N0, luminal A patients, coma with no coma is limiting life expectancy. So for this, more than 70-year-old women with T1 N0, ER positive breast cancer. So where we can give tamoxifen along with tamoxifen along with RT or tamoxifen alone. This study shows the difference of tamoxifen alone and tamoxifen along with RT. So here tamoxifen alone gives more benefit than tamoxifen along with RT. So in such criteria, RT can be avoided post BCS also. So this is the changing paradigms of radiotherapy in breast cancer. So initially it was radical mastectomy, then breast conservation therapy came, then axillary partial breast irradiation came. Then now even for omission of radiotherapy is also there for if no adjuvant RT after BCS for elderly women with low risk or less chances for recurrence actually. So moving on to the next topic, radiotherapy in advanced stage of breast carcinoma. So what is advanced stage means? Breast cancer with no evidence of distant metastasis, resected surgically without prior systemic or radiation therapy. No universal dictum. There is no universal dictum for that. Includes non-inflammatory LABC and inflammatory breast cancer. Non-inflammatory LABC includes stage 3A, 3B, and 3C. So what is the key objectives? Includes PMRT indications, regional nodal irradiation, whether we are going for conventional hypofractionated RT regimen, using of bolus, whether what technique we are using, either 3D CRT or IMRT or VMAT we are using, or even with the techniques, how we are going to treat with the either with the active breath holding technique or deep inspiration, active breath coordinator or a deep inspiration breath holding technique. So these are all different techniques through which we can execute the radiation. So toxicities and palliation. So this is not followed now, but this was earlier followed. Cambridge score for radiotherapy index actually post mastectomy is in post mastectomy is the indication for PMRD. So I'll move on to the next slide. So based on initial stage and response to neoadjuvant CTRT, clinical or pathological stage, stage 3, that is T3, N1 or T4 or N2. High risk stage T2, we are giving PMRT, T1 bar T2 N1 disease with a T3 N0 disease. For young age, LVI triple negative, positive margin, that is or margin less than 1 mm. The tumor confined to central gordons and medial tumors. And the size of the tumors is more than 2 centimeter, grade 3 ER negative. These are all the conditions we have to definitely proceed with the PMRT. So PMRT is 4 to 6 weeks after surgery and or adjuvant chemotherapy. So regional nodal irradiation, positive axillary lymph nodes, negative axillary lymph nodes with PT3 more than 5 centimeter. So negative axillary lymph nodes with PT2 less than 5 centimeter. So in this criteria for negative axillary lymph node with the PT2 less than 5 centimeter, we have to proceed with radiation if it is triple negative breast cancer, central or medial tumor size more than 2 centimeter, grade 3 ER negative and or with a lymphovascular invasion present. So include axillary lymph node level 1, 2 and 3. We have to include the supraclavicular fossa also. Intramammary node is included in if it is a right-sided disease. If it is left-sided disease, if the lesion is central quadrant or medial tumors, we have to include the IMN. Then lateral tumors with more than four or more than 4 lymph nodes positive, we have to include IMN. So supraclavicular node, we have to irradiate supraclavicular region. Indications is clinically N2 or N3 disease or more or equal to 4 nodes positive, 1 to 3 positive nodes with high risk features, positive sentinel nodes with no dissection, then or a positive supraclavicular lymph nodes. So these are the indications for irradiating supraclavicular region. So this is the paper for post-mastectomy radiotherapy. So how we plan for RT? This is the usual breastbone we can see in the image actually. So we have to place the patient in the supine position, arm abducted to 90 degrees or greater. But breastbone is for immobilization. Non-contrast CT thorax with 5 mm cuts to be done. So we have to make a mold actually. Lead markers are placed on the scar and the borders. Whole breast tissue is marked using the lead bias. Bolus used only in PMRT to increase dose to the skin or scar. So the reason of using bolus is when we have to treat the superficial area, then bolus is used. Otherwise, bolus is not used actually. So RT techniques, as I said earlier, it is a conventional RT technique, which is 2D. You must have heard with the cobalt disease. Cobalt mission. Then conformalist 3D IMRT and other advanced techniques. VMAT. So conventional RT, we have to the field borders are suprasternal notch in the medially covering the entire breast tissue. The inferior border is 2 cm below the contralateral breast. Medial is the midline, lateral is the mid axillary line, anterior is at least 1 cm in air. So this is the field borders for old conventional technique using 2D missions. So boost volume is limited. Limited custody is taken to identify lumpectomy cavity and seroma should be seen. The medial and lateral tangential fields planned after taking limited CT. So in this picture, you can see actually, so we have to check for the central lung distance, CLD calculated from the limited CT. So CLD should be less actually. So if it is more, increasing the CME, the CLD, the percentage of lung included will also get increased. So CLD should be less actually. So reduce the radiation-induced pneumonitis for lungs actually. So supraclavicular field is superior is cricoid or 3 cm above medial end of clavicle. The inferior border is lower border of the clavicle. Medial border is 1 cm lateral to the midline or midline with larynx shield. Lateral border is junction of medial 2/3 and lateral 1/3 of the clavicle. So dose is prescribed to 3 cm depth usually for the supraclavicular region. So this is the post-axilla bruise. If axilla separation more than 15 centimeter, dose to the axilla to be falls to less than 80%. So hence boost is required for adequate coverage. Inframedial margin along with upper border of the rib cage. So coming to the conformal RT, nowadays everywhere we have the conformal RT only. Almost 2D has been outdated everywhere. So this we have to plan for a we have to draw the delineation marking should be there for planning. So it should be gross tumor volume, clinical tumor volume, and planning tumor. It's GTV, CTV, and PTV. We have to draw separately in the system, and we have to execute that for the further treatment. Actually, CTV is entire breast lumpectomy cavity plus seroma, excludes skin, chest wall, and muscles plus supraclavicular region. The boost volume includes only lumpectomy cavity. Delineation can be done by clinical definition, surgical scar, surgical clip, ultrasound based, either CT or MRI based, as I told you earlier, 0.5 to 1 centimeter margin to the tumor bed. So this is the treatment plan for breast cancer, where you can see in the left upper in the top picture, you can see the treatment plan with different tangents for the treatment actually. So the second picture also we can see the GTV, PTV, and CTV for the chest wall, along with OR for lung and heart. So prone breast treatment. This prone breast treatment is useful only in early disease when target is just the breast tissue. Usually we never use this. Displaces breast tissue anteriorly and can remove tumor bed or breast tissue from chest wall. For its use especially for pendulous breast. Improves homogeneity for whole breast. Decreases the separation. So very low lung dose can be achieved by this method. Improved cardiac sparing also. Disadvantages, target may be missed actually. So need for the boost for recurrence pattern, 65 to 80% of breast recurrence after BCS or RT occur in primary site. Then pathological basis, low probability of subclinical microscopic disease with increasing distance mets. Primary tumor is more than 1 centimeter. So this is the where we have to give the boost actually with positive margins, undissected DAS or undissected node, or the dose should be usually 10 gray in 5 fractions. So commonly we used to treat breast with these type of dose and fractionation. So first is a conventional fraction, which is 45 to 50.4 gray in 25 to 28 sittings, followed by boost lumpectomy boost 10 to 16 gray at 2 gray per fraction. That is 50 gray in 20 fraction to CTV, boost to 10 gray in 5 fraction. CTV is clinically targeted volume. Then hypofractionation. So this by this method we can treat the patient earlier. 40 to 42.5 gray in 15 to 16 fraction, followed by the boost. 40.5 gray in the gray in 15 fraction, followed by 12.5 gray in 5 fraction boost. Partial breast irradiation, EBRT is 38.5 gray in 10 fraction, 2 fractions per day actually. Brachytherapy, we can give 34 gray in 10 fraction, or IORT for a single setup, we can give 20 gray. Which I told immediately after surgery. So where PMRT can be omitted here. So for patients with node positive TAS disease, patient with node positive, omission of PMRT may be appropriated for selected with PT1 MIC or low nodal burden, N1A disease, followed by axillary lymph node dissection for favorable clinico-pathological features, that is favorable include PT1N2 disease, low to intermediate grade, HER2 positive, HR positive and HER2 negative subtype, postmenopausal status, absence of LVA, and low 21 gene recurrence score. So these are all the recommendations, strong recommendations for avoiding PMRT. So even PMRT also can be avoided in some criteria. So conventional versus hypofraction and RT. So conventional is usually 50 gray and hypofraction is 41.6 or 40 gray, as I told you earlier. There are some 2 trials for START A and START B trial for that. So hypofraction is safe in regional nodal irradiation, weekly 5 days for 3 weeks actually. So bolus, as I said earlier, it is used to treat for superficial tumors. Bolus 1 centimeter or 5 mm over the surface of the chest wall. Routine use is not recommended actually. Indicated if skin dose is inadequate in a T4B disease or inflammatory breast disease. Only when the bolus is used actually. So regarding the techniques, 3D CRT versus IMRT and VMAT, all these are gradually advanced settings actually now, which is followed nowadays. So VMAT has increased the coverage, very most advanced technique. VMAT has with arc therapy, it has increased coverage, better conformity index, better homogeneity index, decreased high dose volumes in OAR. So as I said earlier, this breath holding technique. Breath holding technique is very voluntary. We have to take a deep breath, hold it maximum of at the inspirational level. Recommended for we have to hold the breath for 25 to 30 seconds at least. RT delivered after the breath holding technique. So whereas here the active breath breathing coordinator, it is machine assisted. Patient breathes as per the spirometer, holds their breath and as for the lung volume. Then RT is delivered only after the setting up the lung volume. So here in this breath holding technique, we can see the picture. The first picture is with the active breath holding technique, where the lung is very much inflated and the heart has moved away. So less lung tissues has been getting irradiated. In the second picture without breath holding technique, more irradiation to cardiac and lungs has been noted in this picture. So concurrent targeted hormonal therapy is head-to targeted therapy along with endocrine therapy. So I'll just skip this. It's not much important. So coming to the palliative RT, when palliative RT is indicated to relieve symptoms for stage 4 disease, bone mets, brain mets. Usually we'll give 30 gray in 10 fractions for either bone mets or brain mets. We can also give palliative RT in a hemostatic RT for hemostasis, to achieve hemostasis, which is given 8 gray in a single fraction. So what is oligometastatic disease? So why I'm insisting on this is, usually in previously when we are diagnosed with stage 4 breast cancer, that is metastasis, it won't we are not considering it this treating in a curative setup. Now even with oligometastatic disease, we are treating the breast cancer in a curative and we can treat the patient with in a curative setup actually. So maximum of 5 metastatic lesion, not necessarily located in the same, all potentially susceptible to ablative local treatment is oligometastatic, comes under oligometastatic disease. So evaluation of oligometastatic disease is by whole body PET, biopsy confirmation plus molecular profiling of primary, biopsy of primary site preferably, brain imaging only if symptomatic. So ablative radiotherapy is for brain, bone and other sites. So this is done by SRS or SBRT. Stereotactic ablative body radiotherapy is also known as stereotactic radiotherapy. So SBRT refers to the use of stereotactic technique to direct radiation beams to the desired extracranial site actually. So treatment of intracranial target. So if at all we have a brain lesion, single brain lesion, we can go for SRS and treat the patient very well. Even for liver also we are treating with SRS nowadays. So brain metastasis, SRS alone can be done, or post-operative cavity, SRS can be given, or SRS along with whole brain RT can be given. So we can give, if it is a multiple lesion, whole brain RT can be given, or it is a big lesion, whole brain RT can be given, and boost to the specific site of mets with the SRS can be given actually. So indication for SRS alone is 0 to 2. Up to 4 intact metastasis, lesion is less than 4 centimeter, symptomatic brain metastasis. If it is more than 4 centimeter, surgery or fractionated SRS is indicated. Asymptomatic brain metastasis, we can go as per the MDT discussion. So post-operative SRS, where post-operative SRS is recommended, equivalent survival. Limited brain metastasis, equivalent survival, better local disease with whole brain, local control with whole brain radiotherapy, significantly less neurocognitive decline, risk of leptomeningeal disease is there. So whole brain RT favorable prognosis, not amenable to if not amenable to SRS mean, we can give even hippocampal sparing whole brain RT also we can given. That is better when we give, we can spare hippocampus while giving whole brain RT. Routine post-op whole brain is not recommended actually. Post-op can be considered if more than 4 metastasis. Yes, we can go with SRS plus whole brain RT can be considered if KPS is more than 70. So this is the usual lung dose for so we'll give 10 gray in 5 fraction. So totally 50 gray we can give for lung actually. So for liver we give in 3 fraction 48 to 60 gray if it is less than 3 centimeter. If it is more 3 to 6 centimeter, 60 to 75 gray we can give. If not amenable for surgery, then only for liver RT plays the role. For spine metastasis, we can give 68 gray in 5 fraction if it is single mets actually. Then otherwise for distance multiple mets, we can give 10 gray in 30 fraction. The prognostic factor for better outcome is 1 to 3 metastatic sites, younger age at diagnosis, favorable performance status, longer disease-free interval from surgery, non-triple negative subtype, and no CNS or liver involvement. These are the prognostic factors for better outcome. So the take-home message is modern hypofractionation is safe and effective. DABH or ABC is crucial for left-sided disease, for sparing heart and lung actually. VMAT improves the dose conformity. Concurrent hormonal and targeted therapy are safe. So these are all the area where adjuvant RT is indicated. For adjuvant RT for all BCS except a few where it can be omitted, I told actually. Cases of MRM where more than one positive lymph node, axillary lymph node, T3 disease and T4 disease. For for axillary RT, node positive with extensive nodal extension, sentinel node positive, inadequate axillary dissection. For RT to supraclavicular region, clinically N2 or N3 disease, more than 4 cm with lymph node on axillary dissection, positive lymph node on axillary dissection, 1 to 3 lymph node with high risk fractures, node positive sentinel node with no dissection, high risk with no dissection, RT to internal mammary node, individualized but considered for positive axillary lymph nodes, confined to medial lesion with high risk, stage 3 breast cancer, positive lymph nodes, sentinel lymph node in IMN, positive SCL in axilla with lymphoscintigraphy. Thank you. Any questions, sir?
Thank you, sir, for the wonderful presentation.
Thank you,
Prabhakar, sir. So before Prabhakar sir gives his comment, if there is any questions or doubts from the delegates, you can post it in the chat box or you can unmute yourself. First, Dr. Sairam sir, our National Secretary AMS has raised. Sir, please, sir. Sairam sir.
So post neoadjuvant, there is no radiological tumor visible, and post neoadjuvant treatment, no radiological lesion is visible, and circulating tumor cells are also not visible, negative. So what to do? How to go about?
Sir, I couldn't hear actually. Sir, Ibrahim sir, what is the question, sir?
Sir, sir is asking post neoadjuvant chemotherapy, sir. The primary has disappeared.
Okay, sir.
PET-wise, no uptake, and circulating tumor DNA is also negative.
Okay, sir. So still we have to go for PMRT should be given after surgery. We have to consider RT only with the initial stage of the disease, sir. If it is initially it is T3 or N plus disease, we have to proceed with RT, sir. Even if it is if there is no residual disease after neoadjuvant chemotherapy, we have to give as we are proceeding with surgery after neoadjuvant chemotherapy, even if it is there is no gross tumor, right? So like that, like proceeding with surgery, we have to give radiotherapy also, sir.
If the
Thank you, sir.
surgeon
Prabhakar sir is back. Yes, sir. Sairam sir, please, sir.
If the surgeon says that there is no tumor visible, I will not do surgery, what will you do?
No, sir. We cannot leave the patient actually, sir. We have to proceed with surgery actually. If it is a locally advanced disease where we are giving neoadjuvant chemotherapy and the tumor completely disappears after all neoadjuvant therapy, even at that setup also we have to proceed with surgical intervention. I think Ibrahim sir agree with this for the surgery.
Yes, sir. So there are limitations with all kind of imaging and circulating DNA also, sir. The main limitation is for the PET scan itself, the lesion should be at least 1 centimeter. If it is less than 1 centimeter, it may not be picked up. So when we are giving a neoadjuvant chemotherapy for a locally advanced disease, we need to serially monitor the patient by clinical examination after every cycle. And if the patient has undergone all the cycles and there is no lesion palpable, we have to remove the scar tissue at least. That's why we take the guidance of previous mammogram and also the previous biopsy site, sir. because even sometimes when there is complete pathological response in CT or mammogram or even in PET CT, we can still find isolated tumor cells in the breast tissues itself, sir.
So locally advanced breast cancer, neoadjuvant chemo RT targeted therapy, no response. Can we give neoadjuvant RT?
The neoadjuvant RT is given only in the setup where the tumor is where there is heavy bleeding is there, or there it has to be treated immediately for any particular reasons where chemo cannot be given. So in such cases only we can give pre-op radiotherapy, sir, actually. So if in some cases, even after neoadjuvant chemotherapy, if the surgeon feels it is inoperable or it is inoperable, at that point of time we can give neoadjuvant RT, sir, even to shrink the tumor even more. So amenable for surgery. In that case, we can proceed with neoadjuvant RT, sir.
Thank you, sir. Very well covered. More than any radiation oncologist can forums also. I think that much extensive coverage is not done. Thank you. Excellent
Thank you, sir.
presentation.
Thank you very much, sir. Dr. Prabhuraj, sir. Fantastically you have given your lecture. Sir, you have told something about the intraoperative radiotherapy.
Yes,
And
sir.
you told that only the 20 gray can be given. That
Yes,
is a single dose, sir.
சிங்கிள் டோஸ் சார். ஆமா சார். சர்ஜரி பண்ண உடனே வந்து அந்த இன்ட்ராஆபரேட்டிவ் ரேடியோதெரபின்னு ஒரு மிஷின் அந்த ஒரு இதுல நான் பிக்சர்ல போட்டிருந்தேன் சார். அந்த மிஷின் இருக்கும். ஸோ எல்லா இடத்துலயும் இது இருக்கிறது இல்ல. ஸோ அப்போ வந்து அந்த லம்பெக்டமி பண்ண அந்த சைட்டுக்கு மட்டும் நம்ம கொடுக்கலாம் சார். இன்ட்ராஆபரேட்டிவா ஒரு இது கொடுக்கலாம் சார். ஃபார் பிசிஎஸ் பண்ணிட்டு கொடுக்கலாம் சார்.
அந்த காலத்துல வந்து 5 வீக்ஸ் 5 டோசஸ் அந்த மாதிரி சொல்லுவாங்களே சார். 5 டேஸ் இன் a week ஃபார்
இப்பவும் வந்து கொடுக்கணும் சார். யூசுவலா வந்து நம்ம வந்து ரேடியேஷன் எப்போ கொடுக்கறோம்னா 50 கிரே நம்ம கன்வென்ஷனல் கொடுக்கும்போது 5 days a week தான் கொடுக்குறோம் for 25 sittings. That is for 5 weeks. Weekly 5 days.
This 20 gray is more than enough, sir.
சார் அது வந்து ஃபார் பிசிஎஸ்ல வந்து லம்பெக்டமி சைட்டுக்கு மட்டும் கொடுக்கறதுக்கு சார். அது லம்பெக்டமி சைட்டுக்கு மட்டும் பார்ஷியல் பிரஸ்ட் ரேடியேஷனுக்கு கொடுக்கறது தான் அது. அந்த பார்ஷியல் பிரஸ்ட் ரேடியேஷன் கிரைட்டீரியா ஃபிட் ஆனா மட்டும் தான் அதை நம்ம ப்ரொசீட் பண்ண முடியும். நாட் ஃபார் ஆல் பேஷண்ட்ஸ் சார்.
Not for all patients. Then what are the complications of axillary radiation, sir?
சார் ஆக்சிலரி ரேடியேஷன் வந்து இப்போ நம்ம போஸ்ட் ஆப்ல வந்து எனிவே பாசிபிலிட்டி ஆஃப் லிம்பெடிமா இஸ் தேர். ரேடியேஷன் கொடுக்கும்போது இட் மே இன்க்ரீஸ் ஆக்சுவலி. ஸோ அதர் தென் தட் ஸ்கின் ரியாக்ஷன்ஸ் வந்து காமனாக வரக்கூடியதான் சார். இன்னும் செஸ்ட் வால்லையும் வரும், ஆக்சிலாலையும் வரும். ஸோ அதுதான் காமனாக வரக்கூடிய சைட் எஃபெக்ட்ஸ் சார்.
Okay, sir. Thank you very much, sir. Thank you. Ibrahim, if there are...
Yes, sir. It's a wonderful session, sir. Dr. Nirmal, sir, Chairman, AMS IMT NSB, sir, if you are there, you can give the closing remarks, sir. So any other doubt from the delegates, you can just unmute yourself and ask. I think Nirmal sir is there. Sir, please, sir.
Thank you, Ibrahim. Sorry, traveling. It is nice to hear the wonderful talks on the updates of both cancer talks and the earlier imaging talks. All of them were really eye-opening, very informative, and I'm sure the delegates would have enjoyed listening to the experts. I'm sure got updated with these two interesting specialities. It's a lot to gain from today's knowledge sharing sessions. I'm sure all of you would join for tomorrow's hybrid session on plastic surgery. And if you have any feedback regarding the last 4 days sessions, please share with us so that we can improve our scientific activities through through the Academy of Medical Specialties. And with these few words, I thank all the speakers and the delegates for joining with us for this today's evening session. Over to you, Ibrahim.
Thank you, sir. Thank you once again. So this is the day 4, the consecutive day 4 of the West Zone Amscon. So it's a quarterly program. So today's topic was on fetal medicine and breast cancer. We had 6 speakers today, and the speakers, Dr. S. Lakshmi Ravi, Dr. Devarajan, Dr. Bhavna, and myself, Dr. Ibrahim, and Dr. Said Ismail, medical oncologist, and Dr. M. Prabhuraj, radiation oncologist. So thanks to all the speakers. And above all, the moderators for today's session, Dr. Aishwarya, who moderated the fetal medicine topic on ultrasound and Doppler evaluation, and Dr. Prabhakar sir, Professor, General Surgery Department, Chettinad Medical College, who moderated the sessions on breast cancer. So on breast cancer imaging, recent advances in surgical management, medical management, and radiation management of breast cancer. And he shared his knowledge, and it was a very lively interaction with the delegates also. And I also thank the delegates for their active participation. Above all, today's highlight was we had our AMS national team here, both the chairman and the secretary, Dr. Venkatachalapati and Dr. Sairam. And in fact, Dr. Sairam was very active. He interacted with almost all the speakers and with many doubts and discussions, and making the event very lively. And Sairam sir, if you are there, you want to have any extra information, you can just share here, sir. Any feedbacks you can share here, sir.
Fetal medicine course we should start, sir. If we request madam to start fetal medicine course, we don't have fetal medicine course with AMS. She can submit her course module, and we can get approval, and we can start fetal medicine course, sir. That's lacking, sir. And
Okay, sir.
breast cancer also you can start, boss. Guru.
Thank you, sir. Thank you, sir. Thank you for a wonderful feedback, sir. And also, we'll try to implement your advices from our branch, sir. And Chairman sir is also there here. So thanks for your feedback. And once again, thank all the delegates, speakers, and moderators for the wonderful session. And we will all meet tomorrow live. Tomorrow is a hybrid meeting. So meeting is at Pollachi. And also it will be telecasted both in Zoom as well as YouTube live. And today you can see almost 449 members still here. The time is 6:30, almost 3.5 hours of continuous academic session. And once again, thank you all. We'll all meet tomorrow live. Yes, sir. Thank you. Thank you so much for the wonderful session. Thank you. Thank you, Prabhakar sir, for the excellent discussions and deliberations, sir. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir.